in Dr. Shirumi Madhuwage, the President of the College of the Community Physicians of Sri Lanka, to address you on the topic of public health or community medicine in the current context. A very warm welcome to you, Madam.
Okay, thank you, Tatsara, and warmly welcome all of you to the 2024 MSc screening course, which will be organized by the College of Community Physicians. And at the same time, good afternoon to all of you. And behalf of the college and the council, we all welcome you to this course again. And I think prior to all, beforehand, it's fair enough to say what is College of Community Physicians. And I'm Dr. Shirumi Madhuwage, Consultant Community Physician and the President of the College of Community Physicians. And I'm the 29th President of the College of Community Physicians. And actually, the College of Community Physicians is the apex public health body in the country for public health, especially when it comes to preventive sector and also the health promotion and all the collaborations with doing a lot of activities with collaboration with all the other stakeholders. So we are the key organization in the country. And in our journey, we have started the college initially as the society and then came as this association, then up to college today. And we started in 1927. And the first president was Professor Tulita Fernando. And actually now we have 700 odd membership who are working nationally, provincially, district level, as well as not only within the country and internationally as well. In the Ministry of Health, not only the Ministry of Health, our membership is large crowd of people are working in academia, professors, as well as even in Triforces, UN organizations within the country and away from the country also we are working. So with that brief introduction, I will just step into what is public health, because I feel that with the past experience, this is an annual event that prior to this proper screening and the PGM for experience, we see that more into the public health side. So in the curative side, you feel that and prevent.
So many apologies for the technical difficulties. So the president of the College of the Community Physicians Sri Lanka, she's back, and let's give her the time to express her views. Okay.
Sorry, Tatsara, was it for me? Tatsara, this is Dr. Anuji. Hello?
Dr. Anuji, Shiromi Madam is still speaking, so there was a break in the connection, so we will give her
It's
the time.
okay.
And then
It's
come back to
okay.
you.
Without spending much time, actually, I just wanted to say that public health, when you are engaging in public health, you will experience that at once you will I mean, that community-wise, the large number of people, your service, you are providing the service to the, when it comes to the patient, doctor-patient at hospital setting, one by one, I mean, that one-to-one service is there, but here, at once you give large number of people are getting your service. So for that, you have to be very equipped, very empowered, and you have to be thorough in your subject. So
Thank you so much, Dr. Shiromi Madhuvage, the President of the Committee of Physicians of Sri Lanka, for your enlightening us on the current context of the public health. So now I would like to cordially invite Dr. Anuji Gamage, the Secretary of the Committee of Physicians of the College of the Committee of Physicians of Sri Lanka, to emphasize a little bit more on the topic. So over to you, Madam. A little bit of a reminder to Anuji Madam, you're muted. So
I was speaking. Okay, what is happening today? So good afternoon to all of you. We welcome all of you to this course. I'm the secretary, and this is our 29th council. And I think Dr. Shiromi briefly mentioned about what we do, our mandate, etc. And we are very happy to see your interest shown on public health. I heard that we have about 27 participants, if I'm not wrong. So as a committee, we do a lot of activities for our trainees and for our community, etc. Right? So this is a very noble profession, you know, as Dr. Shiromi explained, a lot of it. This is we focus mainly on prevention. So prevention includes not just prevention, because there are 4 levels of prevention. Okay, so a lot of the activities we do, it's in the community. So as I always tell our students, 20% of the diseases that we have now, all of us being medical officers, 20% of the diseases that we have seen in the clinical setting can be cured. The percentage is 20%. A lot is within the community where people will go to live, work, and play. So there is a lot to do. Right. So I'm very happy. This is your stepping stone. So we take this opportunity to welcome all of you. And I also would like to thank all our resources for volunteering to help us with this. And then I hope you gain information or you improve your existing knowledge, and then come and be a fantastic. These are all budding community physicians that we have. So we sincerely hope that you would contribute to the society and also to the college when you get through this. So without further ado, I will hand over to Dinesh and the team. Thank you very much, all of you, and over to you.
Thank you so much for those lovely words, Dr. Anuji. And now we would like to move on to the next part of the agenda. So the next session would be on the introduction to the course, which would be given by Dr. Najika Chandraratnam.
Good afternoon. Hope you can hear me.
Yes, madam, we can hear you loud and clear.
All right, I'll just try to start my video, but there's a problem with all my Wi-Fi connection, so I'm joining with my phone. All right. Okay. So I'm so glad that we've got more than 25 students for the preparatory course. And it was all the hard effects of the efforts of Tatsara, Dineshan, and especially Dr. Damita. So if I am to introduce us, now Damita is a senior lecturer and a consultant community physician at Faculty of Medicine, University of Peradeniya. He's in the Department of Community Medicine. And then Dideshan, Tatsara and the team are there. Maybe you all have contacted some of us. So they are all registrars, after doing their part 1 in MD, now they are getting ready for their part 2 and doing their course. And I am a senior lecturer in community medicine at the Faculty of Medicine, Colombo. So now this, I'll just first tell you what this, why we have this preparatory course. So, in postgraduate education in medicine in Sri Lanka, almost all, to become a consultant, we need to have a MD. So to become a surgeon, you need a MD in surgery, a physician, MD in medicine. So the same way, to become a consultant community physician, we need a MD in community medicine. So, unlike some of the clinical streams where when you pass part 1, go through part 2 and then pass part 2 after becoming a senior lecturer overseas training, you will become a consultant, right? So that is only MD. But for some specialties, not only community medicine, but medical administration, pathologists, for some streams, we've got MSc plus a MD. So in that, but to become a consultant, you have to go through 2 courses for community medicine. So you may think, now this just prolongs the course. So it prolongs, if you really badly want to become a consultant, why it will take so long to become a consultant. True enough, that is true. But the happy news is, right, there are 2 things that are very happy about. I'm happy about it. Although I am concerned about the long length of our course. One is, unlike the other courses which have a MSc and a MD, or a diploma and a MD, our MSc stands alone, right? Even if you decide after your MSc, no, I don't want to do my MD, or I don't want to become a consultant, your MSc gives you kind of quite a special role in our country and in the international world also, right? With your MSc, there are so many of my friends with the MSc who works in WHO in our country and in other WHO offices, and so many job opportunities in universities with your MSc in community medicine. So that's one thing. And the other is, unlike just having 1 degree, finally we are having 2, right? And our MD is not just a professional degree making us consultant community physicians, but it is also a research degree. So you can always, if you want to become an academic person. Now I decided to become an academic person quite late in my career. I mean, I was in the ministry for 15 years. But once when you want to do academic career, even in outside Sri Lanka, right, your MD MD stands as a PhD because our MD is also a research-based degree. So if you have done your MD for more than 3 years, you can always write to your organizations and write, look, I have a PhD equivalent degree, which is a research-based. So in that sense, you're not so when your MD stands like a PhD, your MSc is the course that gives you all the knowledge or the taught course of it. So in that sense, both the MSc and MD are important. So welcome all of you for this community medicine field and community medicine family, and I'm so glad that you all have decided to do it, because there's a lot of scope in community medicine once when you become a specialist in community medicine, and once when you get an MSc, once when you become a master in community medicine. So welcome all of you for that long journey and the family. So now to introduce the course, the MSc runs for nearly 1 year and 3 months. And what you are going to do is to get selected for this course. So during the course, you will be based in PGIM, and it's a taught course, and there's a thesis. So quite a bit of interesting work plus strenuous work, but it's all taught. Most of it is a taught course. So the screening, which usually happens in the latter part of the year. Now, for that, the college, our College of Community Physicians of Sri Lanka, we call it CCPSL. CCPSL runs this course. So last year I was the kind of coordinator for it, and this year Damita was doing it along with the other gang, the registrar. So this course runs for nearly 17 days. Dinesh, correct me if I'm wrong. It is 17 days. All weekends, Saturdays afternoon, and Sundays full day. So on Saturdays, we usually start around 1 o'clock, because the people who are joining from clinical fields or wards, Saturday is a half-day working day for them. So Saturday we start at 1 o'clock, and Sunday usually by 8:30. Sometimes we start at 8, or sometimes even 9. That depends on the line of lectures that we have for the day, and we usually both days we finish by 4 to 5, no longer than 5 o'clock. So every day we have around 4 to 5 segments of lectures done by different lecturers. So most of them are almost all of them are board certified consultants. But then sometimes when a person is a kind of a very smart person in that area, although he's in the training line, sometimes a registrar or a senior registrar may do a lecture or two also. So that is the timetable and the resource persons. And then what we are going to cover is mainly now in community medicine. If you can recall your undergraduate days, you may remember that we had the basic or the core theoretical subjects, the epidemiology, statistics, and demography. So we learned about those three, the theory of it. And then, the public health system in Sri Lanka. How does public health work in Sri Lanka? So that is we call the preventive health services. So that is done mainly through maternal and child health services, and non-communicable and communicable diseases surveillance. And then there are other services like environment and occupational health, things like that. So all these are covered, and most of the time all these topics, now if it is, let's say, the adolescent health program in Sri Lanka, usually who would come and tell you about that is the national program manager or the high consultant who manages the national program from Family Health Bureau will come and tell you about the national program. So this screening program is quite important for you, not only to learn and get through your not only to get through your screening exam, but also during your MSc days. Believe me, now last time also nearly 95% of the people who participated in the screening course got through their screen, got through the exam, and then I met them at the initial days of their MSc, because I'm the module coordinator for the statistics module in the MSc. So I mean, they were always recalling what they learned during the screening period, and even although I liked a little bit community medicine from the very beginning, from my post-intern days, still I could not recall anything when I went for my MSc screening course. I also went like y'all, and I was just after my post-intern appointment, and we had, those are days that are not very kind of, soft and smooth in life with very young kids and all. So but I managed to go for the MSc screening classes, and I remember all the statistics, epidemiology, everything was very new for me again. I mean, I couldn't recall the things that I learned during the undergraduate days. So it's so good that, you get an opportunity to learn about all those during the screening class. So my advice is, please, first thing is, please, like, pay attention to your lecturers. Now, we were thinking whether to have the course on site or online. I even asked from Dr. Shirami madam whether we should have this online, or can we revert back to on site, because the online thing started after COVID and economic issues and all. But then we thought this would allow all the people from outstation also to participate. Otherwise, it will be quite difficult, hectic for people from outstation to come to Colombo during the weekend to participate. But online again have its own demerits as well, right? Now, teaching statistics in online is quite a difficult thing for a teacher. So what I would ask you is to make your life better, to understand everything better, and to make the teachers or the lecturers' life also better, rather than like we always like to teach to an interactive group of students, right? So please ask questions. If anything is not clear, I assure you, all the teachers, all the lecturers here are doing this voluntary, like nobody's like so because of that, please, like they because they want to teach, all they come and teach. So because of that, please feel free to ask questions. If anything is not clear, always raise questions, clarify your doubts, and then try to sort of recap the things that you learned during the weekend, during the weekdays, so that you are coming quite, quite confident about what you learned during the previous weeks for the next session, and get the maximum out of it. Now, you also have spent money on this, so because of that, also, like, and since you all want to pass the exam, the only trick is, like, at least go through the notes once before you come for the next session. And most of the time, I think even the slides will be shared with you. Very few, I think, will not agree with providing the slides, and definitely the recordings will be shared with you. But then again, please don't share all these recordings with people, like outside people. Like, this is a paid course, so just putting everything in the open domain would not help the college, and would not help you all as well. So, we all are like responsible adults, so don't share the recordings with others. And whatever your suggestions, now most of you have talked one of us, so just whatever your suggestions, if we are too fast, too slow, or we are telling unrelated things, you all are free to tell us, so we can take all these constructive critiques and make ourselves better. So toward the latter part of it, now I said towards the beginning or the first few weeks on epidemiology, statistics, demography, and about the health system in Sri Lanka, and then towards the latter part of it, like starting from day 10, I think, yeah. We are doing day 12. Day 12 to day 17. Those 5 days are mainly to discuss about past papers, and also like model questions, clarify your doubts, things like that. So even for that, if there are things that you want us to discuss, now there's enough and more the resources, material available online also. So if you want to discuss anything with us, please feel free to. Now, once when you know, let's say you learned about descriptive statistics tomorrow, not actually tomorrow, I think it's on the 27th, but if you learned about it, you go and like read more about it. And then if you want something to be clarified, just write to us, okay, we need this to be discussed, so that we have another revision session on descriptive statistics later on I think it's on day 14. So then we can discuss that. So that is how we do it. So I think that's all from me. But if you have any questions to raise, anything to clarify, please ask. Yes.
So thank you so much, Dr. Nadika Chandrathan. Dr. Nadika is a course coordinator of the revision course of the MSc screening program for the community medicine organized by the College of the Community Physicians of Sri Lanka. So thank you so much for your lovely introduction, madam, and all the tips given to the participants. So after the introduction, I would like to move on to our separate topics. So today, the first topic would be done by Dr. Buddhika Mahesh, which would be on the preventive health system in Sri Lanka. And then I would like to remind you of another small change in the timetable, whereas the next session will also be done by Dr. Buddhika Mahesh on the screening for diseases. So a little bit of an introduction of Dr. Buddhika Mahesh. He's a consultant community physician working at the Provincial Director, Health Services in the Western Province. So over to you, Dr. Buddhika Mahesh, starting on the preventive health system of Sri Lanka.
Okay, so thank you, Dr. Tatsara. Can you all hear me?
Yes, sir, we can hear you.
Okay, so the participants, are they, can they unmute? Just one or two, just let me know whether you all can hear me.
Yes, we can.
Yes, sir, we can hear you.
Okay, so I'm going to share my screen, right? Can you all see the screen? Can you all see the screen?
Yes, sir, we can see.
Okay, right. So we'll start the first session. You all can see that it will be on something called preventive health services, right? So we will try to make it as interactive as possible. Okay, so it's not a disturbance at all. If you want anything to ask, just ask at that time itself. No need to wait until the end of the session, right? The more you ask questions, the more you are interactive, the better you can, the more you can gain through this session, right? So keep that in mind, and with that, we'll move into the session. So during this session, there are 5 like areas that we are trying to cover. Okay, so we are going to discuss what is meant by preventive health sector, right? Then how is preventive health sector services organized? Okay, how are preventive health sector services organized? And then a little bit on preventive health staff members. For an example, if you had a question, if they ask something like, assume that you are this person. Okay, and then how would you solve this problem? Then you need to have some idea like where is this person attached to, and what is the expected role of that person. So based on that principle, then we are going to discuss about little bit on preventive health staff members and their roles, right? And then the main topic, that is services offered by the preventive health sector. So that we are going to go into little bit details, and then finally we want to do an exercise, right? Based on what we cover in the first 4 steps. Okay, so make sure that you concentrate well, and if there's anything that you want to ask, again, I am telling you can ask at that time itself. In the last exercise, then I am going to name and ask few people to tell the answers, right? So you have to concentrate fully, otherwise you won't be able to answer the last one, right? Right. So I again invite as many of you as possible to unmute your microphones if there's no background noise. Even if there's any background noise, then we can mute you all, right? So as much as possible, please unmute. The more you interact, the better you can get, right? Okay. As many of you as possible, unmute the microphone. Then you facilitate, and then I can understand that you got what I meant. Right. Then what is meant by preventive health sector? So anyhow, we'll be sharing these presentations, right? So no need to copy everything that you see. Concentrate and ask questions and take things into your mind, right? So that's what is expected from this session. Okay, so can I have few responses? What do you all get when we say preventive health sector? So any answers? So unmute. Then right? May mute that it is not something that I am talking and you all are listening and going. This is a discussion. Can I have few answers? There's no right or wrong answers. You all can tell. What do you mean by preventive health sector?
It is one arm of the health system in the country, which mainly focuses on preventive side.
Okay, so that's a good start. So that answer, it was mentioned that it is one arm of the health sector, and it mainly deals with preventive health side, right? So any other inputs, anything that anyone wants to add?
It should be started from the community, not in the clinical
Okay, so then there's another
setting.
answer telling that it should be mainly at the
Focused in.
community level. Okay.
Yeah.
And then the second part, we will discuss whether it is not relevant to the hospital or not, right? That part we'll discuss. Okay, so any another one?
It can be related to clinical field also. It is depend on the level of prevention, sir.
Okay, so
we can start from the macro level, primordial prevention, or primary or secondary or tertiary. Secondary and tertiary mainly include the clinical aspects also.
Okay, so then there's another suggestion telling that it is relevant to the clinical, it may be relevant to the clinical side also. And then there was another concept that was discussed that there's something called levels of prevention. Okay. And then some words were mentioned telling primordial, primary, secondary, tertiary, something like that. Okay. Right. So getting everything into consideration, now we'll discuss what is curative and what is preventive. Right. So basically, in Sri Lanka, now there is no 100% demarcation, 100% accurate demarcation telling that these are purely curative services, these are purely preventive services, right? And if I tell it another way, you can't say that this institution purely delivers only curative services, this institution purely delivers preventive institutions, because there can be some potential overlap. Now, for an example, we know that hospitals are more related to curative sector. So that is true, right? But it doesn't mean that hospitals do not provide preventive services. Is that clear? Is that clear? Okay. So similarly, you might have heard something called MOH office, right? So it is true that MOH office may be more related to preventive sector, but it doesn't mean that MOH officers do not deal with treatment, right? There can be an overlap. So anyhow, we all agree that curative services are mainly delivered by the curative institutions, right? And then preventive services are mainly delivered by the MOH officers and the other preventive sector. But the first thing that we discuss is that first point is that there is an overlap between curative institutions and the preventive institutions, right? So there's always a collaboration. But mainly hospitals deliver curative institutions, and MOH officers and other institutions that we are going to discuss deliver mainly preventive services, but not 100%, mainly. Are the things clear up to now?
Yes.
Okay, and then there was another point that you all mentioned that curative is more related to single person, and then preventive is more related to community, right? So we'll see. Now, if you go to the, when you get an illness, you go to the hospital or the curative institution to get it treated. So, in the hospital, now let's get a medical ward. In the medical ward, the consultant and the others will be doing a ward round and will go near individual patients, because the management plan related to one patient will not be same for the next one. Okay. So in the clinical setup, we don't tell that give these drugs to all the people in this ward. Okay. This is the management protocol for all the patients. Even let's say that even if a cubicle contain dengue patients, right? We don't blanketly give clinical management guidelines for all 10 dengue patients in the same way. The fluid intake, okay, the monitoring, okay, the date of discharge, okay, the clinical parameters, I mean, whatever the investigations we order will change according to the clinical status and the other details of individual patients, right? So, curative sector or hospital sector, as you all correctly mentioned, mainly deals with individual level care. And there's individual level plans. Are the things clear up to now?
Yes.
Okay, so I want you all to respond. That's why I told you to unmute, right? So then up to that point, we both agree. That means you all also told that curative services mainly delivered by hospitals and preventive services by preventive institutions. And curative services are more related to individual level care. And it's true that preventive services are more related to community level. More related, right? Not all, always. Now, for an example, if you want to prevent alcohol, then we want to prevent alcohol at the community level also, right? So that the interventions we apply is applicable for more than one person, right? So in preventive sector, we mainly deal at the community level, and in hospital, in curative sector, we mainly deal at the individual level, right? And curative services are mainly given by the hospitals and curative level institutions, and preventive services are mainly given by the MOH officers and other related institutions. And also, then if we ask few more differences between curative sector and preventive sector, right? The curative sector, we want an individual level diagnosis. Okay. In the preventive sector, we want something called a community level diagnosis, right? And in the curative sector, people go there when they are ill. So they are already ill. So you will learn a concept called levels of prevention, right? So in the levels of prevention, there are 4 levels of preventions: primordial, primary, secondary, and tertiary. So in the curative sector, since the person is already ill, most of the time is secondary and tertiary preventive methods that are applicable when they are ill, right? In the preventive services, not only that we want to improve the health of one person, but we want to modify the risk factors also. Okay. Now let's get that there's a person with cirrhosis due to alcohol. Okay. So in the clinical sector, curative sector, you have to use the word clinical and curative intellectually, right? It's so not always clinically equals curative. I mean, clinical is not only related to curative. Okay, right? So now let's say that there's a patient with cirrhosis. Now in the curative sector, the management of cirrhosis will be done. Okay, but what is the relevance of that patient in relation to the community sector? Now we see what led this person to get cirrhosis. So let's say alcoholism. Then why people take alcohol? What we can do to prevent people getting alcohol, right? So then what interventions can we do? So we go beyond that individual level management. Okay, we go to the community level. We go to analyze the risk factors. Okay, and we try to modify the risk factors. So with our efforts, not only a single person, but a group of all the community members will be benefited. Is that clear? Are the things clear up to now?
Yes.
Yeah, so if I explain more, let's say there's a person with hypertension. So at the curative sector, the management may be to reduce the systolic blood pressure by 20 mercury millimeters, right? In the preventive sector, the aim will be to reduce the community level systolic blood pressure even by, let's say, 2 units. Then the benefits will be more in the community sector, because when in the community, at the community level, even if a lower level of mean blood pressure drop happens, many more people are benefited. Okay, right? So then the benefits that we get from the preventive sector is more than the benefit that we get from the curative sector. But only issue is that curative sector improvements are apparent very quickly, right? We can say that when the person goes to the hospital, he gets cured, he or she gets cured, right? So quicker results are seen, right? Because of that, it may looks very glamorous, right? People go there with illnesses and come out without illnesses. Whereas in the preventive sector, we deal with risk factors and we deal with primordial, primary, secondary, tertiary, all levels of prevention. And the results may not that be obvious. Okay, will be obvious with time, but mean for a lay person, it may not seem so glamorous. For an example, let's say we vaccinate people, right, to prevent them getting measles. So quite a lot of thousands and thousands of children are prevented from getting measles. But let's say a child get measles and go to the hospital and come back. So the people can see that there's an improvement. But that prevention we created in thousands and thousands of people may not be visible to the people, right? But anyhow, the benefit is more. The people who know can understand the gravity, right? But for a lay person, it may not that be very glamorous. So that is why, community medicine and those things, even in your undergraduate level, you also may have thought that as a very boring subject, and you know that not given adequate emphasis to the level that you are giving to the other that curative level specialties, right? So that is why, I mean, it may not look glamorous at the first look because the results may not be obvious to the layperson. So are the things clear up to now?
Yes, sir.
Yes.
Yeah, but in the long run, so if you analyze deeply, the benefits given by the preventive sectors to the society is far more than the benefits we give at the curative sector, because curative sector, we focus on one person, right? So the benefit is for that. Anyhow, indirectly, when one person is benefited, the family members are benefited. That's true. But at the community level, thousands and thousands of people are getting benefits, right? So think in that line. So curative sector, preventive sector, we looked at some service, some differences, right? So you can see that the picture in the left side is more related to the curative sector. You can see that we are dealing with one person. And then there are, well demarcated boundaries called hospitals, and then there are security staff, and then that other people are not allowed to come in. So there's some secure background is there in the curative sector, right? We are a little bit separated from the community, right? So we are the kings and queens there. We are deviated from the community. But you can see on your right side, it's a clinic set up at the community. One MOH is doing a clinic. So you see open to the public, no security officers, right? People can directly come and contact you, right? We deal with the community. So we have to deal with the politicians, the people, alcoholics, the people who sell alcohol, okay, and all we are exposed there, right? So the responsibilities are more. That includes more traveling. In the hospital, we deal within the ward, right? And sometimes there may be outreach clinics. But in the MOH level, more traveling, right? Okay, so are the things clear up to now? So those are some of the differences in the ways that we provide services in the curative and preventive sector. In the curative sector, people come to the hospital and we deliver the services at the hospital or the curative institution, right? In the preventive sector, people come to the clinics, okay? But clinics are not separated from the community, within the community. And also, we give services going to the houses of the people also, that we will discuss in a while. So are the things clear up to now?
Yes, sir.
Okay. Now we'll get another example. Let's say that there's a bridge, okay? And the bridge breaks down, okay? And the people fall into the river, right? And we take them to the hospital, and in the hospital, the people are managed, right? So what will happen if we focus after the second step, that means people are in the river now, right? we are quickly taking them out and taking them to the hospital. Then what will happen? Again, another day, this may happen, and we have to again take them to the hospital, right? Okay, but the solution is where? I mean, if you want a stronger solution, then where should we aim at? What should we do? Rather than waiting until the people are in the river, what should we do?
Build a stronger bridge.
Yeah, we should ensure that the bridge doesn't break, right? So it's like that. Curative sector is like that. When people get ill, we treat. That is also a very good, great service, right? So we are not telling that we are the people more important, but we are telling that we appreciate the curative sector services, but what will be more cost effective now, rather than waiting until several buses go on the bridge and the people fall into the river and take them to the hospital? Then some may become disabled, some may die, okay, some survive, okay, but all can be prevented if the bridge can be made stronger, right? So that is the theory of community medicine. We deal with the community, we deal with the risk factors, okay, and we try to prevent people getting diseases. It doesn't mean that we have no role when the person is ill. As you all mentioned, there's something called secondary and tertiary prevention that we also apply, right? But we are more focused on making preventing people getting ill, which is more cost effective and also provides more benefits to the people, right? So in an angle, community medicine is a specialty that links curative services with the community. Okay, we link curative services with the community. So are the things clear up to now? Are the things okay?
Yes.
Right. Now, if we take another example, right? Let's say there's a patient with some renal problem, right? So what will happen if it gets complicated? Then we have to go for dialysis, right? Then let's say if there's a person with blocked coronary arteries, right? Then what will happen? Ultimately, we will have to go for a coronary artery bypass graft, right? But if we can prevent this atheroma from developing, if we can prevent this renal failure from happening, right? We can prevent many people who need dialysis. We can treat many people who need CABG, right? That will save more money to the country, and that will provide more quality of life for the community members also, right? So that is the importance of community medicine again, right? So with that background, we'll go into see how the preventive health services are organized, right? So can we have few answers? How are the preventive health services organized in this country? If you get this question for your exam, describe how preventive health services are organized in Sri Lanka. What will you write? What will you write? Now to make it easier, we'll see how curative services are organized in the country, right? So if someone asks how curative services are organized in the country, we will say that there is something called curative institution categorization, right? We will say that there's something called curative institution categorization. Now, can you tell that curative institution hierarchy? What is at the top?
So we can
National Hospital and
central institute under the central government and provincial government.
Okay, so that is a good start. So that is one way of categorizing. Before going into that, let's say that types of curative institutions. How can you categorize? Now let me know whether something happened to the screen sharing. Can you all see the screen? Can you all see a slide called levels of healthcare versus curative?
Yes.
Yeah, so you can see that at the top we are having national hospitals, right? Let's say Colombo, Kandy, like that, right? Then we have other teaching hospitals, because national hospitals also are teaching hospitals, right? Except for national hospitals, there are other teaching hospitals, right? For an example, let's say Colombo South Teaching Hospital, right? Colombo North Teaching Hospital, right? Okay, then those are examples of other teaching hospitals. Then we have provincial general hospitals, like let's say Ratnapura, Badulla, We have district general hospitals. They'll say Kalutara, Nigambo. We have base hospitals. Okay, let's say Homagama, Vatupitivala. Okay, then we have divisional hospitals, right? Let's say Maligavat, right? Aturugiri, right? Then we have primary medical care units everywhere, right? Okay, right. So this is how the curative services are organized in the country in the hierarchy of curative institution categorization. Is that clear? Is that clear?
Yes, sir.
Yeah, so
Yes.
you need to know this, right? Because now, if you get a question like how the health system in Sri Lanka is organized like that, so you should have a holistic idea like how the curative institutions are categorized and how are they distributed and how the preventive health sector institutions are categorized, right? Anyhow, this part is clear to you. You know that there are national hospitals, other teaching hospitals, provincial general, district general, base hospital, division hospital, primary medical care units, right? So if I tell few details about that, you know, primary medical care units do not have inward care, right? Divisional hospitals above, we have inward care. Is that clear? Is that clear?
Yes, sir.
Yeah.
Yeah. And we know that base hospitals and above, we usually find consultants. Is that clear?
Yeah.
Yeah, rarely maybe in a divisional hospital, there may be a consultant in the transitional period. The divisional hospital becoming a base hospital in the transitional period, you can find a consultant, but you know, generally we find consultants base hospital and above. Since consultants are there base hospitals and above, intern medical officers are also usually found base hospital and above. Are the things clear?
Yes.
Yes.
Yeah. So you see that in the divisional hospitals, we find doctors, but no consultants. So you have to keep in mind, right? So if we ask what changes you propose to the system in the country, before writing the answer, you should have an idea. Primary medical care unit is like an outpatient service, right? So no inward patients. Divisional hospital, inward patients are there, no consultants. Right? Base hospitals and above, there are consultants, right? So that categorization should be there in your mind, right? So before coming into that point, now let's say, before we should discuss how preventive health sector services are organized, we have to discuss something called levels of healthcare. Now, I told earlier there's something called levels of prevention. So what are the 4 levels of prevention we told? Primordial,
Primordial, primary, secondary, and tertiary.
Primordial, primary, secondary, and tertiary, right? Okay, so if I just share my whiteboard. Can you all see the whiteboard?
Yes.
Yeah, now let's say there's a person, right? So this is primordial. Okay, this is primary. This is secondary. This is tertiary. Right? Primordial means we want to prevent risk factors occurring in the community, right? Primary means we want to prevent the person getting the disease. Second, now here, from here onwards, person is having the disease, right? So secondary and tertiary prevention we are doing when the person is having the disease. So you have to keep that in mind, right? So when the person is having the disease, in the secondary prevention, we aim to minimize complications. Right, so our aim is here minimizing complications. Secondary, tertiary complications are there. So we want to minimize the disabilities in tertiary. Right, so let's get an example. Now we want to prevent a person getting hypertension. Okay, if we want to make a person getting hypertension, that means the person is not having hypertension now, right? Then primary prevention. Is that clear?
Yes, sir.
Yeah. So what do you do to make a person get what can you do to prevent a person getting hypertension? We can tell them to maintain their BMI.
Salted.
Okay. Yeah. Salt minimization. Okay. And then engaging in physical activity. no alcohol, no smoking. I mean, that for that person, right? So if a person is doing exercises, preventing this sedentary behavior, not getting alcohol, not getting smoke, and then not getting excessive salt, then those are examples of primary preventive strategies for that example. Then let's go one step before that. That is, what are the risk factors for hypertension? So we know for risk factors for hypertension is physical inactivity, overweight and obesity, smoking, alcoholism, incorrect diet. Now I am taking a few examples, right? And then let's say mental stress also. Right. So then what can we do to prevent those risk factors occurring in the community? Then those activities go under primordial, right? So let's say to prevent physical inactivity, a government can make what? Walking pathways. Can encourage office people to do exercises by introducing something called exercise hour, right? So like that, I'm taking some examples to prevent obesity. Okay, so again, the similar things. Then for prevent smoking, we have pictorial warnings in the cigarette packs. We have smoking-free places. We increase the taxation of cigarettes, right? So all these are going under primordial prevention, right? So are the things clear up to now?
Yes, sir.
Yes.
Yeah. Now let's say we cannot prevent these risk factors, so the person gets the hypertension, right? Now we want to prevent complications. Now tell a complication of hypertension. If the hypertension is so much, what can happen? The person can get a what?
MI or stroke.
Yeah, let's get
Stroke
stroke.
or
Yeah, person can get a stroke. Then what are the things that we can do for a patient with hypertension to prevent that one getting the stroke? So the things are that we should detect hypertension early, and we should treat early, and we should do the evaluations early. So those are going under secondary prevention, right? Early identification, early referral, early treatment, right? Now let's say unfortunately that person got stroke, then the complication has happened. Then what do we do to minimize the disabilities of that person? We do rehabilitation. Let's say physiotherapy for physical disability, minimization. Counseling for psychological disability, minimization, right? Then vocational for financial loss, right? Then some social, household level modification for social rehabilitation, right? So those rehabilitation things going under tertiary prevention. So are the things clear? The levels of prevention?
Yes, sir.
Yeah, so there must be another session on this, right? So I am just telling because you need to apply these levels of prevention to this, and you need to differentiate these levels of prevention with levels of healthcare. That is why I'm telling. I'm telling this, right? So with that background, if we go to the our presentation again, so there we want to discuss something called levels of healthcare. So, there's a concept called levels of healthcare. Now, can you see the presentation with something called levels of healthcare?
Yes.
Okay, right. Then there are 3 levels of healthcare: primary, secondary, tertiary. Again, I am telling you have to differentiate levels of healthcare from levels of prevention. So there are 4 levels of prevention and 3 levels of healthcare, right? So 3 levels of healthcare: primary, secondary, tertiary. Before telling what is primary, we'll tell what is secondary. Secondary means basic specialist healthcare, right? Specialist healthcare. Now, if you think of a hospital, base hospital, what are the general 4 specialties that we find in a base hospital traditionally? Surgery, medicine, gyn-obs, and
Pediatrics.
pediatrics. Okay. So if a curative institution is having those 4, we can tell that that is a secondary level institute, secondary level curative institution, because secondary level means specialist care. Tertiary means, in addition to that basic specialties, if there are subspecialties, let's say rheumatology, cardiology, oncology, okay, oncosurgery, let's say neurosurgery, pathology, whatever, then if those things are rheumatology, right? Okay, so like that, I mean, if those subspecialties are there, or teaching facilities are there, right? For an example, if you get Castle Street Hospital for Women and Disoisa Maternity Hospital for Women, you find only pediatric and gyn-obs there, right? But again, it is a teaching hospital, so then it goes under tertiary. So when it is subspecialty or with teaching facilities, those are categorized as tertiary, right? So tertiary subspecialties are there or teaching levels are there. Secondary means basic specialties are there. In contrast, primary means Now you can see that operationally, consultants are not there in primary level. Okay, but that is not the way to define that. How we define primary is that primary services should be made available everywhere in the country. Now, if you tell something as a primary healthcare service, a person in Anuradhapura need not come to Colombo to get that. That one should get that from the Anuradhapura, right? A person in Jaffna need not come to Kandy or Anuradhapura to get that service. That should be available everywhere. Okay? The services that should be available, accessible, and affordable everywhere in the country are called primary healthcare services. Are the things clear up to now?
Yes, sir.
Yes. Yeah. So then, if something to be available everywhere in the country, now, if that service is needed to be given by a consultant, consultants are limited. So if there's any service that should be given by a consultant, it cannot be categorized as primary health care because primary health care should be made available everywhere, in every village. Okay, to the every villager, the primary health care services should be accessible, affordable, and available, right? So with that background, think some examples of primary healthcare services. I will tell few examples. You all tell me whether those are primary healthcare services or not, right? Ultrasound facilities, primary or not?
No.
No, need not be available everywhere, right? So people who need that, we can refer them to a station, right? Bypass surgery, primary or not?
No.
No, because we can refer them to, refer whoever the people who need that to that institution. Okay, so it need not be there made available in every MOH level or Gram Nidadari level or divisional secretary level. I mean, there can be some selected places people can be referred. Family planning services.
Yes.
Yeah, so everyone in Sri Lanka should have access to family planning services, right? Growth monitoring services.
Yes.
Yes, primary healthcare. Antenatal services.
Yes.
Food safety services.
Yes.
Yes. Okay. So those are a few things that we told in relation to the prevention. Okay, let's say that that those are related to more to the MOH setup. Now let's get a little harder question. Treatment for common diseases.
Yes.
Yeah. Now let's say somebody gets a upper respiratory tract infection, right? Upper respiratory tract infection, general upper respiratory tract infection. Okay, should that person from Polonnaruwa, a rural area in Polonnaruwa, should he come to the Polonnaruwa General Hospital to get treatment for that?
No.
No, he should be able to go for any general practitioner, any primary medical care unit, any divisional hospital, right? If they can be treated there, then no issue. Is that clear?
Yes.
Is that clear? Yeah,
Yes.
so then treatment for common diseases is a primary health care, right? Let's say somebody gets a simple laceration and needs suturing. Okay, needs suturing. Should that be primary health care?
Yes.
Yes.
Yeah. So let's say somebody in Gampa in a rural area, in a rural setup need not go many miles to get it sutured, right? Okay, let's say femoral fracture. Should there be primary care?
No.
No.
No, so that one needs some more specialist opinion and all. Okay, so like that, services that should be made available, affordable, and accessible to everyone in the country, right? Those are categorized as primary healthcare. So this is how the World Health Organization defines primary healthcare, right? WHO defines primary healthcare as essential care made universally accessible. So what we call accessible, right? To individuals and families in the community by means acceptable to them through their full participation and at a cost that the community and the country can afford at every stage of development. Now this definition, I mean, you may find it little bit complicated, but there are three concepts hidden in this. One is that it should be accessible, right? Then something called at a cost that they can afford. That means affordable, right? Okay, and available, right? So what is the difference between these three words: availability, accessibility, and affordability? Think with an example. how will you explain the differences of the word availability, accessibility, and affordability with an example? Now, what is that contraceptive method where two rods are there, two rods are placed beneath the skin?
Jadel insertion.
Yeah, so it's generally called implant. Okay, and two-rod implant. There are two varieties now. Generally, Jadel. There's another variety now which is there for 3 years. Jadel is for 5 years, right? Implanon is one rod that is for 3 years, but I'm telling recently there's another type, two rods for 3 years.
Yes.
Right? Anyhow, let's get that example. Now without complicating, let's get one rod implant. One rod implant, that is called implanon, right? So somebody wants to get an implanon inserted. A family wants the woman in the family to get a implanon inserted, right? Implanon, is given by the MOH officers, right? So should that MOH area have a family planning clinic?
Definitely.
Yes.
Yeah, so then that is called. But let's say the clinic is in a very far away place where bus is not there for some people in that MOH area. People in a corner of that MOH area, they don't have any transport mechanism to come to that clinic. So even if the availability is there, then what is not there now?
Accessibility.
Accessibility is not there, right? Now, let's say in another country, availability is there, accessibility is there, but they give that service to money. They charge. So a family do not have money to buy that. Let's say in another country, because our country, these are free of charge. No? Then in that country, availability is there, accessibility is there. Then what is not there?
Affordability is not
Yeah,
there.
affordability is not there, right? Okay, so availability means that the presence of that service. Accessibility is whether a person can reach that service. Affordability is whether any financial restrictions are there to get that. Okay, so is it clear the difference of these words? Is it clear?
Yes.
Yeah.
Okay, and then usually the primary healthcare setup is the first contact point a person comes into the health system. Think of the hospital. Now, if one of your relatives get let's say abdominal pain, with your knowledge, clinical knowledge, you differentiate whether they should go to the medical clinic or surgical clinic, right? Because abdominal pain for you is not a disease, it's a symptom. So you think about the disease. But for a lay person, that is a disease. The disease is abdominal pain for them. So they go to the OPD. OPD will direct them either to the medical side or surgical side. Is it clear?
Yes.
Yeah,
Yes.
so that the OPD is an example of first contact point. The people coming to the health system through the OPD, right? So that is why we told even national level hospitals provide primary health care. Why? All these hospitals have an OPD. Is that clear?
Yes.
Yeah, but within the OPD, there can be secondary services also, because there's someone called VP OPD. Then there's a specialist in OPD. Is that clear?
Yes.
Yeah, so routinely OPD provides primary care, but in some settings, there may be primary or secondary, depending on whether there's a consultant or not, right? So that is why you have to you have to take these concepts into your head and apply accordingly. Right, up to now, we have discussed the difference of the terms availability, of accessibility and affordability. And if there's any service that should be available, accessible and affordable anywhere in the country, those services are examples of primary healthcare services. So these are some examples of primary healthcare services. Treatment for common diseases, treatment for common injuries, antenatal care, vaccination, family planning, growth monitoring, food safety, water quality, health education, and all, right? Out of them, you all know that first two, treatment part is usually given from the curative sector. Are the things clear?
Yes.
Yeah, and to deliver these curative services, we discuss what is the hierarchy that is there from the national hospitals up to the primary medical care units, right? And to deliver these preventive type of services, preventive types of primary healthcare services, we have an organization in Sri Lanka that is called what? What officers?
MOH.
Yeah, we have MOH officers. So think in that line, right? Okay, so if somebody asks what is an MOH office, you can say that MOH office is the health unit that is there in Sri Lanka to deliver primary healthcare services in relation to the preventive sector. Examples, antenatal, vaccination, family planning, growth monitoring, food safety, water quality, health education, and all, right? But always remember that there's an overlap, right? Sometimes these two services, that treatments may be provided from the MOS setup. We give sometimes drugs, okay? You know that for pregnant mothers, we may give some supplements, right? So like that. And from the hospital sector also, they give preventive services, right? So there's an overlap, but mainly the treatment component is done by the curative sector, and then the preventive part done by the preventive sector, but always there's an overlap, right? Okay, so then we discuss this, and we discuss this. And if we just apply the levels of healthcare to the hospital hierarchy, divisional hospitals and primary medical care units are called as primary level institutions. We name them by the highest level of care they give. So divisional hospitals and primary medical care units, they don't usually provide secondary or tertiary. So the highest level they give is primary, right? Whereas these other hospitals, they provide secondary and tertiary also. And in addition, they provide primary, but we name them by the highest level. So we name them as telling secondary and tertiary level institutions. So are the things clear up to now?
Yes.
Yes.
Yeah. So now think there can be many questions up to this point. I mean, if they can ask, what are your suggestions to improve primary healthcare system in Sri Lanka? If you get a question like that, what are your suggestions to improve the primary healthcare system in Sri Lanka? Then it should be clear to you that primary healthcare for the curative services means divisional hospitals and primary medical care units, whereas other hospitals also provide primary healthcare in addition to secondary and tertiary, right? And then again, it might include general practitioners also. Okay, that is when the people are ill. And primary health care for the preventive component, all these antenatal vaccination, those are also primary health care services. Is that clear? Is that other things clear up to now?
Yes.
Yeah, okay. So then when we say primary health care, these preventive components also should come into your head, right? But if they say primary health care in relation to curative sector, then this summary should come into your head. Right. What is a common problem that we come across these days? In divisional hospitals, can deliveries happen?
Yes.
But are we getting that much deliveries in primary? I mean, that means divisional hospitals?
No.
No.
No, because labor rooms are there, midwives are there, right? Okay, all facilities are there, but deliveries are not happening. I mean, not the complicated delivery. If the delivery is complicated, then definitely it should be transferred to the higher level. But the problem is that people are bypassing primary level institutions and getting congested at the secondary and tertiary level, right? Even for, let's say, other clinic settings, you might not get many people to the primary medical care unit and divisional hospitals, but many at the higher level. If you get numerically, you know that there are more base hospitals than district general, more divisional hospitals than base hospitals, more PMCUs than divisional hospitals. So by number, when you go down the hierarchy, the number of institutions are more. Is that clear?
Yes.
Yes.
Yeah, so that means they are more scattered. The lower level institutions are more scattered and closer to the people because they are more in number. So if we can improve the quality of services by these primary healthcare institutions, what are the benefits we can get? It will reduce the congestion at the secondary and tertiary. And also it will prevent people uh, getting delayed admissions, because when they have to go for a longer distance, right, they will stay in the house, they will do self-medication, and only when the complications are there, they go to the hospital. But if we can improve the quality of these divisional hospitals and PMCUs, people have more access to them because the lower level institutions are more in number. So they will go to the hospital earlier. They will go to the curative institution earlier. Okay, before getting complicated, right? So it will be more cost effective to the government in the long run. Is that clear?
Yes, sir.
Okay, right. So those are some concepts, right? So we saw that MOH setup is there to deliver the primary healthcare services for the preventive services mainly, right? And in MOH offices, up to now that consultants are not there at the MOH office itself, right? That is one reason why we call that as a primary healthcare institution, right? So the answer for our question was how are preventive health sector organized? If you get such a question, you can say that preventive health sector is organized with the organization of preventive health sector. We can describe under 4 levels. National level, which is the central level, provincial level, regional level, which means the district level, and the divisional level, which means the MOH level, right? So we can tell the organization under 4 levels: national level, provincial level, district level, and the divisional level. So national level, which is called the central level, we have the Ministry of Health and Family Health Bureau, Epidemiology Unit, Health Promotion Bureau. All these programs and campaigns, they go under the national level. So are the things clear up to now?
Yes, sir.
Yeah, at the provincial level, every province is having a PDHS office, and in the PDHS office for this preventive services, there are 4 units. What are the 4 technical units in the PDHS office? There's a planning unit, there's a family health unit, there's a epidemiology unit, there's a environmental, occupational health and health promotion unit, ENOH and health promotion. So those are the 4 units at the provincial level: planning, family health. Family health means what you call as maternal and child health. The correct word is family health, right? Planning unit, family health unit, epidemiology unit, ENOH and health promotion unit. So the NCDs go under the last one, ENOH and health promotion, right? So there are CCPs, consultant community physicians, posted under for these four technical units: CCP for planning, CCP for family health, CCP for epidemiology, who is called the provincial epidemiologist, and then CCP for ENOH and health promotion. Currently, all those vacancies are not filled. So you find that many vacancies are there, but in future they will be filled. So 4 community CCP post at each PDHS office. Is that clear?
Yes.
Yes.
Yeah, and in addition, many CCP posts are there at the central level. In the epidemiology unit, there are several CCP posts, family health bureau, several posts like that. Central level also having CCP posts. Then district level. District level headed by the regional director of health services, provincial level by the provincial director of health services. So district level also same 4 units: planning unit, epidemiology unit, family health unit, ENOH and health promotion unit. Okay, so in future there will be 4 consultant community physicians at the district level, right? Now this I told epidemiologists. Now regional epidemiologists, so RE is the name that we give to the epidemiologists at the district level. Okay. Now you may find that currently there are some REs who are not CCPs, right? That is because some years back there were no consultants at the district level. So in the annual transfer list, the post was given as the RE. So when there's a medical officer as a RE, even though that one is not a consultant, until he leaves that post, the word RE will be given, because otherwise it's not nice, no, right? So what you should take into mind is that when we say RE, there are CCP REs, and currently there may be MOREs who got the placement some years back. But now the annual transfer list doesn't advertise any post called RE in the MO list, right? In the grade medical officer list, no post is advertised as RE. That post RE is advertised at the CCP list, consultant community physician. So you should know that you all will become CCPs, consultant community physicians. So CCP is the title that we tell for a consultant in community medicine. Is that clear?
Yes, sir.
Yes.
Okay. And at the MOH level, CCPs are not there, but all the national, provincial, district CCPs help the MOH officers. Okay, and they deliver their functions that we will discuss later. right? Okay, so this is the public health organization. If you go into details, right? No need to by heart, you all know. At the central level, we told there's a minister, and in some governments, there will be state ministers, there's a secretary of health, there are additional secretaries, director general of health services, and deputy director generals. So there are four deputy director general posts, 4 DDG posts, which are directly related to public health. DDG PHS 1, DDG PHS 2, right? DDG food and DDG food and ENOH, right? And then DDG NCD. So like that, there are some DDG posts directly related to the public health, and also DDG planning also related. So like that, I mean, many of the DDG posts are related, but basically these four are more related. DDG PHS 1, DDG PHS 2, DDG Food, Environmental and Occupational Health, and DDG NCD. Okay. Right. And then you have, national level institutions and special programs and campaigns like, Family Health Bureau, Epidemiology Unit, Health Promotion Bureau, National Dengue Control Unit, Anti-Filariasis Campaign, Anti-Malaria Campaign, National STD and AIDS Control Unit, National TB and Chest Disease Control Unit, okay, Cancer Control Program. So like that, those are examples of special programs and campaigns. So they all are under these DDGs, relevant DDGs, and they are falling under the central level. Is that clear?
Yes.
Yes, sir.
Yeah. And in each of these places, like these national level institutions and special programs and campaigns, there are CCP posts, right? And provincial level, PDHS is the head, and there are CCPs and other medical and non-medical staff. At the district level, RDHS, CCPs, MOAP, MOMCH. So like that, those are there. So, in the RDHS office, I told 4 CCP posts are there. So other doctors who are in the epidemiology unit are called MO epidemiology. Now the current, this annual list will advertise some posts as MO epidemiology. Similarly, MO maternal and child health, right? The consultant is called the CCP family health, right? So in that unit, the MO will be called as MOMCH. Is that clear?
Yes.
Yeah, and regional supervisory public health nursing officer, we call as matron, right? And then SPHID, that is supervisory public health inspector at the district level, right? Regional dental surgeon, food and drug inspectors. So those are some examples of people at the regional level, right? We should know in and out about this divisional level people. So let's move into the divisional level now. Divisional level, now we have MOH areas. Now these are some of the norms. We like to have one MOH area for 60,000 people, right? But currently, I mean, there may be some MOH areas which have more than 60,000 people, right? So, but the large areas are broken down into two. Now, for an example, now in Colombo district, if you get Colombo, there are 18 MOH areas. Colombo RDHS area, 18 MOH officers are there. Some time back, there were no 18. Okay, if I tell you few examples, earlier there was one MOH officer called Kaduvela. Now it was broken down into two called Kaduvela and Battaramulu. Earlier there was one called Gotatuva, there was one called Kolonnava. Now it was broken down into two called Kolonnava and Gotatuva. There was one called Homagama. It was divided into two called Homagama and Kahatuduva. There was one called Morotuva, broken down into two called Morotuva and Egoduva. So like that, the larger ones are being broken down into two. That is why we say around 360 MOH areas are there. Are the things clear up to now?
Yes.
Yeah, and these MOH areas, there are like that. I mean, we have not built a wall between two areas. Now, let's say Kaduvel and Battaramula, there is no wall or gate separating those two. But with the natural boundaries, everybody is clear. What is the boundary? For an example, beyond this bridge, beyond this river is this MOH area, and this side, this MOH area. Like that, there is no repetition. Everyone is crystal clear. So every household knows what is the MOH area that household belong. Is that clear?
Yes, sir.
Yeah. And then you see that we like to have one public health midwife for 3,000 people. So in an ideal, in a MOH area with 60,000 people, then there will be around 20 public health midwives. Is that clear? Because we like to have one per 3,000. Are the things clear?
Yes.
Yes. And then we like to have one PHI, public health inspector for 10,000 people. So in a MOH area with 60,000 people, there will be around 6 PHI, 6 public health inspectors, right? But currently I told there will be more people for one staff member, but you know, this is the aim that we are looking at. Right, let's see some of the pictures. So the gentleman in the middle is the, can you all see my cursor moving?
Yes.
Yeah, so the gentleman in the middle is the MOH. You can see that he is wearing a trouser and a shirt. So like that, MOHs can wear a suitable dress for a doctor or the navy blue uniform that curative sector people are wearing, right? So whatever is okay. A dress suitable for a doctor or the navy blue uniform, right? Right. Then this one is a public health inspector, right? This one, you know, public health nursing sister, right? PHNS. This one, supervisory public health midwife, SPHM, right? Okay, and these, the one that I showed earlier, this one is a public health midwife, right? You see that this is their new uniform, right? This is their new uniform. This was their earlier uniform, right? You can see that they also have trade unions and all. So some of them maybe wearing the old uniform still. Okay, but whereas the new people will be wearing this uniform. So you can see that, I mean, that is also in the transitional phase, right? So anyhow, this is the new uniform that they are wearing. Some maybe still wearing the old one according to their preference, that we have no problem with that, right? So this is the public health inspector. This gentleman here next to the MOH is the supervisory public health inspector, right? So you see that the badges that he is wearing will be different from the badges which this one is wearing. So are the things clear up to now?
Yes.
Yes.
Yeah, so you saw some of the staff members in the MOH office. There's doctors, right? Doctors are there. Supervisory public health inspector and then public health nursing assistant, supervisory public health midwife are there. And then we have plenty of public health midwives and public health inspectors, right? So then what about the ratio of the doctors? Now I told then one PHI per 3,000, one PHI per 10,000. Then what about the doctors? For 60,000 people, we like to have 2 doctors, right? 2 MOHs, right? And for every additional 30,000, we like to have another one. Okay, so harder positions are given 30,000 per doctor, right? And it starts with usually 60,000. Is that clear? So usually 2 people are there, and then with every additional 30,000, a new cadre will be there. Is that clear?
Yes.
Yeah. And these MOHs, what's the difference between MOH and the AMOH?
They are usually
Yeah, usually.
newly post intern appointments.
Cannot a young doctor, younger one become MOH and an older one be the AMOH?
Can be.
Can be. So you have to keep in mind that MOH means medical officer of health, right? And all 3 letters start with capitals, right? AMOH means additional medical officer of health, not assistant, right? Additional medical officer of health. So when 6 doctors are there, let's say in an MOH area, 6 doctors are there, one is the MOH. MOH is the head of the institution, right? All other doctors are called AMOHs, right? So whether you are a MOH or AMOH depends on at the time that you get the appointment, right? When it is advertised, some posts are advertised as MOHs, some as AMOHs. Okay, that is why you find that there's a senior person working as an AMOH, whereas a younger person may be there as a MOH, because the post they applied was MOH, whereas the post that the other person applied was the AMOH. Is that clear?
Yes, sir.
Yeah, but anyhow, you know, they collaboratively work. Usually there are no problems between MOHs and AMOHs. The MOH is the head of the institution. So the financial responsibilities and the organization responsibilities, signing the letters and approving the leaves and all lies with the MOH. Whereas all other technical things, conducting clinics and doing services and all other things are equally done by MOHs and AMOHs. So are the things clear up to now? Are the things clear?
Yes, sir.
Yes, yes.
Yeah, so MOH level staff members you can categorize into two levels, supervisory officers and grassroots officers, right? So supervisory means MOH, AMOH, PHNS, SPHM and SPHI, right? Usually the supervisory officers, supervisory officers can supervise the grassroots officers, right? Grassroots means they are more close to the community, right? So the grassroots officers are traditionally PHM and PHI. So supervisory officers supervise these grassroots officers. Supervising means not just giving any advices, right? They should fill a form called supervision report and submit that, okay? And when they supervise, the way that they supervise depend on the subject area also. We find that midwives are more related to the maternal and child health, right? So supervisory officers for midwives will be doctors and PHNS and SPHM. SPHI, though categorized as a supervisory officer, will not supervise PHM because the subject area is different. Is that clear?
Yes.
Yeah, whereas SPHI, that is Supervisory Public Health Inspector, and with the MOHs and AMOHs, they will supervise the PHI, right? So you see that the doctors can supervise any of them, whereas other supervisory officers, according to their category only, right? Okay, so basically the staff members at the MOH office, we can divide into two. Supervisory and grassroots, again, according to the type of service, maternal and child health versus disease control and environmental and occupational health. There should be word disease control is missing here, right? Disease control, environmental and occupational health. So PHM involves more in maternal and child health services. PHI more in disease control, environmental and occupational health services. But always there's an overlap. Is that clear?
Yes, sir.
Okay, so these photos we have gone through. Again, I am showing. This is the MOH, public health nursing sister, supervisory public health midwife, supervisory public health inspector, public health midwives, public health inspector, right? Right. Then what are the services offered by the preventive sector, right? So you should remember that the services are usually given at the implementation level, right? That means if you consider the place where people get the service, it is always the MOH level. Is that clear? Even though we have provincial, district and all, provincial, district and national level, right? Usually the people comes into contact with the MOH level. Is that clear?
Yes, sir.
Okay, so then MOH level is the service providing level for the people. And all the higher levels are there to facilitate that implementation level. So the policies and all will be laid by the national level. And they will be communicated or coordinated to the implementation level through the PDHS and RDHS officers, right? So basically the policy development, the guideline development done at the central level, and services given to the people at the MOH level, the provincial and district level will help the coordination of MOH level services, right? So when we take, so these we discuss, when we take maternal and child health services, there are two ways that we give the services, right? Maternal and child health, right? What are the two ways that we give the services? People come to the clinics, right? So there are every public health midwife area. Now we told that now let's make it more easier. Now let's get this is an MOH area. So MOH area is divided into areas called PHM areas. So PHM area, what's the approximate number of people we told?
3,000.
3,000. And then PHI area, what's the approximate number?
10,000.
10,000. So you can see that one PHI area generally will include 3 PHM areas, generally. Is that clear?
Yes.
Yeah, so you should keep this in mind. Now, if we can, this PHI area, there may be an opportunity if this PHI and PH 3 PHM and PHI of this PHI area, if they can get together and discuss some of the services. Now, for an example, usually the school vaccination, school health part is done by school health part is done by PHI, public health inspector, right? School health part. But let's say that there's a child not coming, not attending the school, right? PHM visits the households. There are something called home visits. So PHM knows that this child is there. Okay. Then if these two can collaborate, whoever the children who are not coming to the school and not got the ATD vaccine, the PHI can get these details through the PHM. So that type of a collaboration is possible if the PHM and PHI of that area collaborate. So there's a structure for that, which is called the local conference. Is that clear? There's something of the local conference. Local conference is expected to happen at PHI area level. That means the PHI and the 3 PHM should monthly have a discussion on the services given to that area. And from the MOH office, someone will visit. Some supervisory officer will visit that meeting. So what is that called? That is called what?
Local conference.
Yeah, local conference. Keep that in mind, right? And then we have the MOH office at the middle, right? We usually place the MOH office at the middle where then, because it is equally accessible to all the people from the other sides, right? And then there are, in relation to the maternal and child health, there are two types of services that we give. People come to a setting called clinics. Okay. Those are called clinic-based services. And some services we give by going to the home of the people, houses of the people, which is called domiciliary services. So there are clinic-based services and domiciliary services. So to do clinic-based services, we have different types of clinics. We can categorize them in many ways. One way is that the bigger clinic at near the MOH office, okay, is called the central clinic. Usually the central clinic is functioning on Saturday morning, right? Saturday morning we are having the central clinic, whereas clinics of each PHM area functions in the weekdays. Those are called field clinics. So let's say this is PHM area 1. They have a clinic on, let's say, every second Wednesday and fourth Wednesday, right? So whoever the children who miss that clinic, children or pregnant mothers, whoever who miss that clinic, come to that central clinic on the nearest Saturday. Is that clear?
Yes.
Yeah. So that's the difference between central clinic and field clinic, right? And also, depending on the types of services given, we may be given, there's only one family planning services in this clinic. That is called single clinic. If we give all the services, polyclinic. So like that, I mean, you will learn this when you get the lecture on maternal and child health services. I'm just roughly telling that the clinics can be divided as central and field based on whether they are functioning on weekdays and in the weekend, right? And types of services, single, combined, or polyclinic. So anyhow, those are the clinic-based services. Other things clear up to now?
Yes.
What is what is, yes?
Can you please explain the difference between the central clinic and the field clinic?
Okay, right. So now we told that every MOH area is divided into PHM areas, right? And every PHM area is having a clinic, which is called the field clinic. Is that clear?
Yes.
Yeah, and in addition, there's the clinic called Central Clinic, which is usually located near the MOH office. Usually, right? Usually, the same building, you have the MOH office, and one part of that building is arranged as a central clinic. That means the clinic facilities are there. The central clinic usually functions on Saturday because it is meant to function, it is meant to deliver services for the people who miss the field clinics. Is that clear?
Yes.
Yeah, so we encourage people to come to these field clinics, but if they miss the field clinic, so who are the types of people who miss the field clinic? Let's say working people. Okay, working pregnant mothers, they cannot go to the field clinic, they have to come to the central clinic. And let's say on the field clinic day, one child is ill, so cannot give the vaccine. So once they are settled, they can come to the nearest central clinic. Okay, if the child is having some minor allergies, right? Then the doctor decides that the child should not be given vaccine at the field clinic, but need not be sent to the hospital also, because it's not kind of a severe thing that we are suspecting, but something, I mean, the better observation is needed. So then they will decide that this child will be vaccinated at the central clinic. Okay, so those are some examples where who are the eligible people to come to the central clinic. So are the things clear?
Yes.
Okay, right. Then every public health midwife is having an office. Okay, every public health inspector is also having office. Office means it's not a very 2 or 3 room offices, but single roomed office, right? We will discuss these things later when we are doing questions and answers, right? So there's a MOH office, right? The supervisory officers are there in the MOH office. That means the doctors officers are there in the MOH office. Public health nursing sisters office also there in the MOH office. Supervisory public health inspectors office is also there. Supervisory public health midwives office also there, right? So all the supervisory level officers are there in the main MOH office building. Is that clear?
Yes.
And the public health midwives and public health inspectors are having their officers in the field. Okay. Because of that, the public health inspectors and public health midwives, daily all of them need not come to the MOH office. They are not expected to come to the MOH office daily. They go to their office and do whatever the things are there, and according to their plan for the month, they go to the field or the community, right? And in the last hour of the day, they come to their office again to do the relevant documentation. Okay. There are 2 days of the month that everybody come to the MOH office. One is called the monthly meeting, which is called the monthly conference. Is that clear?
Yes.
And what is the conference? I told earlier that public health inspector and the relevant public health midwives can do that. I told another conference. What is the name?
Local conference.
Yeah, that is a local conference. So local conference is a smaller type of meeting where the PHI area related people are there. And the supervisory officers are also coming to that, right? Monthly meeting means all the MOH staff members will be at the monthly meeting, monthly conference. Is that clear?
Yes.
So if you want to meet all these people, you cannot just go on any day and think that all will be there. They come there on the monthly conference day. And also there's one day of the month which is called the in-service training day, right? In-service training day, where one day of the month is meant for training. For the in-service also, all people are coming. So usually there are 2 days that they all are coming to the MOH office, the monthly conference day and the in-service training day, right? Okay, and then in addition to the structures that we mentioned, there are something called weighing centers. That means when we want to weigh the children, okay, we are weighing the children according to protocol. Like, I mean, you will learn this later. Children up to 2 years, their weight is measured monthly. After 2 years, once in 3 months, like that. Okay. So if all the children come to the field clinic to get their weight measured, then there will be congestion. Okay. Because of that, we have some selected places called weighing centers. Okay. And the people, usually they are at the peripheries so that we can reduce the congestion at the field clinic, right? Okay. So, and those are called weighing centers. They need not necessarily be buildings. It can be open space also, right? They say in front of this temple and in this playground like that. But people know where is the weighing center and what day it is functioning. Is it clear?
Yes.
Usually we don't start the weighing center early in the morning, right? We usually start the weighing center. We start the weighing at 11. Okay. Why? Then it will give some time for the midwife to do some other work in the morning. Otherwise, if they just start weighing the children from early morning, that day is lost. Is that clear?
Yes.
Yeah, and what instrument they use for weighing and all other things you will learn later, right? So anyhow, that is the structure of the MOH office that we discussed up to now. Now, you see that PHM, all people, PHI, then doctors, all are doing some community service, right? Not unlike in a hospital. Now, all are not within the hospital every day. You see that MOH might need to go to conduct a clinic, might need to go to conduct school health activity, or to meet the divisional secretary, or for some investigation of a communicable disease, right? So they are not expected to stay in the office, right? So then what they do is, before the end of this month, let's say this is July, before the end of July, I will, if I am the MOH, I will prepare my schedule for the next month. Okay. And I will write that down on 1st of August. I will be doing this. 2nd of August, I will do it like that. So that is called the advanced program, right? And I get the advanced program approved from my my immediate supervisor, right? And then I will document that. And I will paste that in my office. So anybody who comes, let's say somebody comes to meet me, I am the MOH. If somebody comes to meet me on 16th of August, I am not in the office. So that one can go through the advanced program and see where this person is at this moment. Is that clear?
Yes.
Yeah. So then that is how it is happening, right? So people, supervisor officers and all other staff members come to their offices in the morning, and according to the advanced program, they occupy with their work, right? So if you want to meet all people at the same time, then you have to go either on a monthly conference day or on a in-service training day, right? And then there are many arrangements that are done for monitoring and evaluation of the services, right? So every supervisory officer is expected to do some supervisions per month. Doctors need to do 6 supervisions, right? PHNS should do 6 supervisions. SPHI and SPHM should do 10 supervisions per month, right? So like that, they should supervise the people and supervise the settings, clinics and services, okay, and send their report to their supervisor, right? Or their immediate supervisor, right? And there are review meetings at MOH level, district level, provincial level and national level. So all the data and everything discussed and the weaknesses identified, strong points are appreciated. Okay. So a very good monitoring and evaluation system is there. Okay. Are the things clear up to now?
Yes.
Yeah. And there are some, unlike those days, now all the services are not paper-based, right? Now we have electronic systems, right? Now, in your faculty days, you might have heard something called WRCD, Weekly Return of Communicable Diseases, right? It is prepared on Friday evening and posted on Saturday morning. So, and you might have seen one old answer telling that it is prepared in 3 copies, 1 copy kept in the office, 1 copy sent to the district level, 1 copy sent to the appeal unit. Now those are history now, right? They will prepare that and electronically we submit now. Okay. Like that for the maternal and child health services also, there are electronic systems, which is called ERHMIS. Okay. And then the earlier system that I mentioned for this communicable diseases are called e-surveillance. Then similarly, there's a e-NIP surveillance. Okay. Electronic system for National Immunization Program. So like that, things are being converted to e-systems. Keep that in mind. So it is not a very static, old-fashioned system being modified, right? Keep that in mind. Huh? And then if we just go through some of these maternal and child health services a bit more, all the maternal and child health services are given according to something called life cycle approach, right? So life cycle approach means you can see a person's life cycle, starting from the pregnancy, then a child. Then there are different terminologies that we use. We'll discuss that later, right? Who is a neonate, who is an infant, who is a young child, who is a preschooler, who is a school child, who is a teenager, right? Okay, who is a well woman, right? Okay, so then there are different categories that we name. And there are services as a package for these categories. Like that for pregnant mothers, there are antenatal services. After delivery, there are postnatal services. Then in the first year, there are infant services. Okay. Second year, there are services for young children. Then between 2 to 5, there are services for preschoolers. Okay. All are well planned and well developed as a package of services. So every preschooler is eligible to get all the services that are there in the package. Is that clear?
Yes.
Right. So that is called life cycle approach. That means we deliver the maternal and child health services according to the life cycle approach, right? Then if we just go into few details, we have antenatal and postnatal services, right? Some services given at the clinic, some services given at the home. What is the name we told when we go to the house and give the service?
Field.
Domiciliary.
Home visit.
Field means clinic and domiciliary both. Okay. So domiciliary means giving to the house, going to the house and delivering the service, right? Okay. So what's the word? Domiciliary. Is that clear?
Yes.
Yeah. So this is left side, you have an example of clinic-based service. Right side, you have an example of domiciliary service. Then for growth monitoring, that is also one type of service, right? So there are different instruments to make different frequencies. You will learn them later. Then well baby clinics are there. Vaccination services are there, right? There's something called EPI schedule. You will learn them, right? Vaccination schedule in Sri Lanka, right? Then for school children, we have school health services, including school medical inspection. Well women clinics are there for 35-year and 45-year-old women, right? Family planning services are there, right? Okay. So then all are examples of maternal and child health services. Are the things clear up to now?
Yes.
Okay, so I am not going into details because there's a separate lecture for this maternal and child health services, right? A detailed one, right? And then the other type of service. Now we told that the services can be divided into two at the MOH level, maternal and child health services and disease control, environmental and occupational health services, right? So under the disease control, we have, now who is the person who is more related to this out of the grassroots officers? PHM or PHI?
PHI.
Yeah, for these type of services, the PHI, right? So for them, we have surveillance system. There's something called notification system, right? Then you should know why notify, what are the objectives, who should notify, when to notify, how to notify, what to notify. So like that, you will learn. There's something called list of notifiable diseases. And when a medical practitioner meets a patient suspected of having a disease, he should fill a form called H544 and send to the relevant MOH office. And from the MOH office, it is given to the relevant PHI and the notification register updated and the PHI, which is the house, and documents what he does there in the form called 411 and sends that back. And if it is confirmed, then these days entered to the infectious disease register and another form called 411A is filled. Then on Saturday evening, everything is compiled into WRCD and it is sent to through the e-system on Saturday morning. So like that, there's a system which is called the notification system that you will learn. Okay. So these are the forms and documents related to that examples, H544. This is the notification form, right? And then, so notification, you will learn that there are 3 group A diseases and then group B diseases, right? Okay, so any medical practitioner should start a process called notification when they meet a patient suspected of having any disease, right? Suspected, remember, no need to wait until getting confirmed, right? And this is the notification system. I am just summarizing, there are separate lectures for these, right? Then there are other services for disease control, communicable disease control. Okay, other than the notification system, there's something called surveillance of special disease, special surveillance of diseases that need special surveillance. There's something called sentinel surveillance. There's something called outbreak investigation, right? There's something called active surveillance. And okay, and there are services that we give for leprosy patients, leptospirosis patients, okay? So like that, rabies. So there are different things that you will learn. Okay. Right. Then non-communicable disease control, we have something called healthy lifestyle clinics that you will learn. Okay, they are basically conducted in curative institution settings, right? So that you will learn, right? And then through the MOH offices, we give food safety and water quality services. You will learn those also, right? We expect that every public health inspector to get 2 food samples per month, right? And from the MOH area, we expect that there will be 6 water samples. Okay, so like that, you will learn those services what are under the food safety. There's something called inspection of food handling establishments. Then there's a form called H800, which we use to grade the food handling establishment. Then there's food sampling. Then there's household level advisors, right? And there's street vended food. So all services are going under food safety. So water quality also different services are given. Then there are occupational health services. Okay, delivered related to the occupational settings. So are the things clear up to now?
Yes, sir.
Okay. Now I will ask some questions. Now you will quickly tell me. Yes, I know now. There's one of your colleagues is asking, is it possible to share the slides? Definitely we'll share the slides, so no need to write down anything. I mean, no need to write down everything. Just listen, right? Okay, now I will ask some questions. Now take 30 seconds and digest what we discuss. The person I'm asking the question should tell the answer, right? Unless there are volunteers. Right. So if we ask few differences between preventive health sector and curative sector, I will tell some statements. You all tell whether those they are more related to curative sector or preventive sector, right? Individual level care.
Curative.
Mostly, right? Community level care.
Preventive.
Preventive.
Preventive. And risk factor management.
Preventive.
Preventive.
Okay, risk factor management. I mean, you know that at the individual level may be related to curative sector also, but as a whole, more related to preventive sector, right? Okay, and community level diagnosis.
Preventive sector.
Preventive sector. Okay, so you see that those differences we mentioned. Then organization. What's the hospital categorization? Not on top, we are having national hospitals. Then below that.
Teaching hospitals.
Always tell other teaching hospitals because national hospitals also are teaching hospitals, right? So national hospitals, then other teaching hospitals, then provincial general, district general, base hospitals, then divisional hospitals and primary medical care units. Right. So out of these hospital hierarchy, what are the institutions that are categorized as primary level?
Divisional and the PMC.
Divisional and primary medical care units. Right. Then what's the difference between this primary, secondary, and tertiary? What are the essential elements of primary healthcare services? They should be available,
Accessible, and
affordable. And also, usually they are the first contact points a person present to the health system, right? Okay, then the examples of primary healthcare services we discussed, right? Then MOH office. I will tell few statements. You all tell me whether they are true according to the MOH office or not. Consultants are there. No. But consultants, they help in all the processes. Not directly attached there, right? More related to curative sector.
No.
Right? Okay. More related to secondary care.
No.
No, then what's the answer? More related to?
Primary.
Primary care. Right, okay. Right. Then what is the approach that we use in the maternal and child health services? What approach? We told that different life stages are there. What is that approach called?
Life cycle
A life cycle approach. Right. And then how can we divide the staff members in the MOH office under what two main categories? According to the type of service.
Maternal and child health.
Yeah, maternal and child health and
Disease control, environmental health, and occupational.
Disease control, environmental and occupational health, right? Then according to their level, supervisory or
grassroots level.
Now, again, one thing additional, right? Now, except these officers, right? Except these staff members, there are other staff members also, right? For an example, all MOH areas are currently having a type of staff member who are basically, they are mosquito control activities. They are called Maduru Mardana Sahayaka, right? SKS is also general term, but the specific term is Maduru Mardana Sahayaka. Okay? Okay, and other than that, there are drivers. There are development officers for management assistants for clerical work. Right? So you should know that it's the office level, other members are also there. Is that clear?
Yes.
Right. And then tell me, maternal and child health, what are the 2 ways that we deliver services?
Domiciliary level and
Domiciliary level and the
clinics.
clinic based level. Right. What's the difference between MOH and AMOH?
technical part is always same as
Technical
MOH.
part
Okay, technically part all are same. And the head of the institution is
MOH.
MOH. All others are called AMOHs, right? So I will tell few staff members, you all tell to which level they belong, national, provincial, district or MOH level, right? PHI,
MOH.
MOH level. SPHI,
MOH.
MOH. SPHID,
District.
district level. And I didn't tell that you should know that there's someone called SPHIP also, right? In some provinces.
Province.
Okay. So that one is at the provincial level. Is that clear?
Yes.
SPHIP is at the provincial level, right?
District level PH is also there, no, sir.
This
Combined
sorry, district level?
PH is maybe in the district level also. Combined PHs.
Yeah. So district level, now we'll go to that. Now district level also, there's SPHID also, they are the RDHS office. And as you all mentioned, now this is the general structure of the RDHS office. And as you all mentioned, there can be few PHIs at the district level also. Like, let's say, how is this leprosy control activities are conducted in Sri Lanka? What is the National Institute for Leprosy Control? There's something called anti-leprosy campaign, right? Under the anti-leprosy campaign, they have a PHI in each district. That one is called leprosy control PHI. Okay. So that one also attached to the RDHS office. Is that clear?
Yes.
Similarly, rabies control. There's an organization called Public Health Veterinary Services that coordinates the rabies control activities with the involvement of EPID unit and the MRI, right? So under that, there's someone called Public Health Inspector for Rabies Control. So that one is also at the RDHS office. Is that clear?
Yes.
And how is malaria control and filaria control activities are conducted? There's an anti-malaria campaign and anti-filaria campaign. They have a medical officer called anti-malaria officer, anti-filaria officer, right? Okay, who are doctors. Okay, so there's one anti-malaria medical officer for malaria control in every district. Medical officer for filaria control also under every district. So they are technically under the national program, but attached to the RDHS office. Is that clear? Salary is given from the RDHS office.
Yes.
So are the things clear?
Yes.
Yeah. So you see that now with the time, because this is the first day that some are exposed to this, I'm not like just asking this more of the names, but you should have some idea like how are they placed, right? Okay, now tell Director General of Health Services. What level?
Central.
National.
Central. Okay, central or national, both are same. Then Deputy Director Generals.
Again, central.
Central. Family Health Bureau.
Central.
National Dengue Control Unit.
Central.
Consultant Community Physicians.
And this is provincial or regional?
District.
Central, provincial or district. Okay, so is that clear?
Yes.
Right. Regional Dental Surgeon.
District.
Yeah, whenever something is started with regional, I told that regional means district. Okay. Right. So that's that. And then I will give you one question now, right? Okay, now tell me how many people, we like to have one PHM per how many people?
3,000.
3,000. One PHI per?
10,000.
10,000. 2 doctors per?
60,000.
60,000. Then with each additional 30,000, another additional doctor, right? Okay. And should the supervisory officers do something called supervisions monthly?
Yeah. Definitely.
Yes.
Yeah. So doctors, how many supervisions per month?
6.
6. Okay. Then what are the 2 days that all staff members gather at the MOH office?
Monthly conference and
Monthly conference and in-service training. What is that type of meeting that happens at the PHI area level?
Local.
A local conference, right? Okay, so we discuss all that. Okay, then what is the document that all staff members mention their next month's plan?
Advanced program.
Right? And these, especially these field officers, last hour of their day, they should be at where? Their
Office.
office to document what they did on that day, right? Okay. Now, what are the working hours for MOH officers? Now, now it's the old answer. If you say something like, let's say 8 to 4:15 with one hour for lunch in the middle, that is the old answer, right? Now, MOH working hours, same as hospital working hours. Okay, 8 to 12 and 2 to 4, and Saturday half a day. Is that clear?
Yes.
Okay, so it doesn't mean that 12 to 2 we are not delivering services. We are delivering services, but now officially the working hours are 8 to 4 and 2 to 4. So if you work between 12 to 2, then you can claim extra duty. So I mean, like that administrative structure. So you have to learn. And when a doctor is positioned as MOH or MOH, usually how long they should stay in that office? Now that is same as the hospital doctor. So what's the departmental procedures? One appointment is given usually for how many years?
Maximum 4 years.
Yeah, 4 years. But if you do a postgraduate training, then no need to wait until the replacement. You can directly come, right? So when you get through this screening exam this year, then you can start the MSc course directly, right? You need not, in the annual transfer list, after you get some placement, sometimes you are not released until there's a replacement. But for postgraduate, no problem like that, right? Okay, so those things you should know, and the working hours we mentioned. And what is called the central clinic?
It's happening near to the MOH office.
Yeah, happening in the emergency on what day?
Saturdays.
Saturday. Meant for what? Meant for what people?
Working.
Okay, the first answer is for the people who miss the field clinics. Yeah, so the name for the other clinics is the field clinic, right? So who miss the field clinics, right? Examples of people who miss the field clinics include working mothers and children who were ill on the field clinic, like that. Is that clear?
Yes.
Right. Now let's say that there's a pregnant mother from Jaffna, okay? Came to stay here in Colombo for 3 months. Can she attend antenatal clinics? Let's say now
Yes.
she's in Dehiwala, but her hometown is Jaffna. She's in
Yes,
Dehiwala for
temporarily
3
we can.
months. Yeah, so can she attend Dehiwala clinics?
Yes.
Yes. Now we don't have any restriction. If there's a valid reason, we offer that service without any restriction, right? Okay. Only when in special residence before giving that, right? But for all these services we discussed today, if there's a valid reason, then setting doesn't matter. Even if you are staying for a temporary period, you can get that service from there. Is that clear?
Yes.
Right. And we ensure that the continuity of care, if someone is, let's say, from the Dehiwal area, one family goes to the Polonnaruwa, then the MOH office will communicate with the Polonnaruwa MOH office and will let the children continue their child health development records and all these things from there. Right? We say that up to now we have given this, you continue, right? Okay, so like that, we also ensure the continuity also, and there are particular registers and returns that you will learn later, right? So final question before we wind up. Now it was supposed to end at 2:30, right? So we just extended a bit because I felt that, I mean, some of you all are new to the system. That's why I explained a little more. Doesn't matter because this hour is also for me, and then even later also there are sessions for doing questions on epidemiology. So whatever we cannot cover for screening today, we can cover inside those sessions, right? So let's get the concepts clear because this is the first session that gives the introduction to the system. So you all should be very clear of all the basics, right? So that is why we are taking time and doing this, right? So the other sessions will be a little faster. Is that clear?
Yes.
Okay, now think of this. How does the curative sector institutions collaborate with preventive health sector in the provision of healthcare for the public? If you get this question, what will you write? Think. I'll give you 1 minute to think. Right. Let's get some examples. Tell an example where both sectors collaborate and give the service. Let's get a pregnant mother. Do the pregnant mothers attend the MOH clinics as well as the hospital clinics?
Yes.
Yes.
Yes. And the records, now the same pregnancy record, can the hospital people also write there?
Yes.
Yes. Okay, and do all the pregnant mothers refer to the hospital from the MOH office when they come to the first clinic, which is called the booking visit?
Yes.
Yes.
Yes. So what is that model called? That model in Sri Lanka for pregnant mothers is called the shared care model. You will learn that later, right? That is one example how curative sector and preventive sector collaborate. Now let's get a disease, dengue. How hospitals and MOH officers collaborate in providing dengue services related to dengue control to the public.
Notification.
When okay, so when dengue suspected dengue patients are there in the hospitals, they will notify. Okay, there's a different system to notify, which is you will learn that later, right? There's a system called NATSIS, National Dengue Surveillance System. Those things don't worry today, right? So anyhow, to that system, they will from the hospitals, they will notify. Okay. And then from there, the process, the cycle we discuss, notification register, the PHI go in there, so that will be initiated, right? And then the relevant MOHs will get the details of the relevant patients, and from the MOH level, the relevant field investigations will happen. Is that clear?
Yeah.
Yes.
Okay, so that is another example how curative and preventive collaborate. Now, let's get a child coming for vaccination. There's a child with some kind of allergic history, or let's say with some risk factors that we feel that it's better not to vaccinate in the field setup. Better to vaccinate in a setup where some more emergency facilities are there. So can the MOH refer that child to the MOH, to the hospital to
Yes.
arrange the vaccination at the hospital setup?
Yes.
Yes. Okay, another example. So like that, many examples are there. So let's say when the pregnant mother is coming, pregnant mother comes to the MOH clinic, and the doctor feels that there's fundus is less than dates. Can the MOH refer that mother to the hospital?
Yep.
Yes.
Yes. So, and another example, we find that the blood pressure of the pregnant mother, we are suspecting pregnancy-induced hypertension. Can we refer?
Yes.
Yeah.
Yeah. So again, you see that many collaborations are happening. Okay. And let's say there's a child, newborn child, who have come from the hospital. Now, midwife goes to the house to deliver domiciliary services, right? There are something called postnatal home visits, right? And then the midwife finds that there's some problem with the milk secretion. Okay. She does the initial things, and at the MOH level, their interventions, I mean, they do the interventions, but this problem is beyond their level, right? So can they refer them to the something called lactation management center at the hospital?
Yes.
Yes. So like that, I mean, you should have many things in your head if they ask collaboration between hospital and the MOH office. These are examples, right? So you can add some theory, some concepts, and then write. Okay. Anyhow, so first, so what we'll do is we'll take a very short break. Anyhow, we have another 15 minutes, right? So in that 15 minutes also, we'll take a 2-minute break, and then we'll move into the next topic, which is the screening. So we will start screening, and don't worry, now we have many sessions in future. So we'll do the rest of the screening in one of those sessions, right? But anyhow, we'll be starting in 2 minutes. Okay. So are the things clear up to now?
Yes.
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 Okay. So take a 2-minute break. Right, can you all hear me?
Yes, sir.
Okay, so the next one, the next topic that we have to cover is called screening for diseases, right? So now can you all see the screen?
Yeah.
Okay. Right, then there are two objectives of this session. One is to be familiar with concepts related to screening, right? And then to go with some, go through some past questions and see what type of questions and ask, right? Anyhow, at the end of this course, there will be some sessions that will be there for you all for targeting the past questions. But here also, like, we'll try to see what type of questions and ask, right? And then if you see the topics that we will cover, then you have to appreciate what's the difference between a screening test and a diagnostic test, right? Then what are the ideal diseases that we can apply screening? Then what are the features of an ideal screening test? Then what do you mean by sensitivity, specificity, positive predictive value, negative predictive value examples, right? And then how do you select screening tests? Then what are the types of screening programs? How will you evaluate screening programs and some past questions, right? So before we proceed, now let's see some of the, now these are some types of questions that you get. Now for the exam, now from today itself, you target the exam, right? Now this is not, you all are not medical students that just come and listen to these sessions. Now your intention is to get through the exam, right? So you should have an idea about how the exam structure, how many questions are there. So how many questions are there?
Five questions.
Okay. And how long you have to answer? I mean, total paper, how long?
3 hours.
3 hours.
Okay. So can you access past papers online?
Yes.
Yes.
Yes, you can go to the PGIM website and there's a section called past papers and select community medicine. And then under community medicine, there will be 4 or 5 categories. Screening course for MSc, then MSc exam past papers, MD selection past papers, then MD past papers. Okay, so like that, you select screening exam for MSc. Then they will show the past papers by the year. So you can download. Okay. maybe there may be 1 or 2 papers that you are not accessible. Then if in that case, you can get from people who, I mean, your previous people also, then they also have all the set of past papers. So if anything is not there, right, you can get from other people, right? So anyhow, at least be thorough with past papers of last 10 years, okay, before going to the exam. So under the exam, as you all mentioned correctly, there will be 5 questions, right? And then the 5 questions, each will carry 20 marks. So 20 into 500. So even if you write 3 questions very, very well, but 2 questions nothing, then the maximum mark you can get is 60. But you know that when you are writing answers, I mean, you can get, I mean, good marks, but always we are not sure now whether we get 100 marks. Okay. But for some questions, like when their calculations are necessary, statistics and epidemiology questions, if the answer is correct, then full marks you can easily get. Okay. So like that, you should have a plan, right? Anyhow, what I'm telling is that you should write all 5 questions, right? With I mean, don't like you don't have an idea like I will write whatever I can. No, you should write all 5 questions. You can write all 5 questions, right? And you have time, and then allocate some time for one question, and then after when the time is over, go to the other question. Don't spend the full time again and again on the one question, right? You can complete the other questions and come back and do the rest. Okay, so that's also simple things, but anyhow, you will learn more about those things later. But anyhow, in those questions, now these are some questions that are related to screening. So see what kind of questions that ask, define the term screening, right? And then there's can you all see my screen?
Yes.
Yeah, then you can see that so that carries 20 marks. So you need to have an idea if the paper is 3 hours, then if you have like if you spend if the question is 3 hours, that means 180 minutes. Then 5 questions. So then for one question, 36 minutes. Out of that 36 minutes, let's say you can spend about 5 minutes for planning the answer. Okay, plan the answer for 5 minutes. Then you have 30 minutes, roughly. Okay, and that 30 minutes is for 100 marks. Then for 10 marks, you can spend 3 minutes. Is that clear?
Yes.
Yeah, then let's say for this question, define the term screen, 20 marks. So how many minutes can you spend? You have 30 minutes for 100 marks. So for 20 marks?
6 minutes.
6 minutes. So you can roughly get an idea. Now, always people ask how long to write like that. So that depends on the time that is given. Okay. So you can generally think that, I mean, this type of question, you have 6 minutes. If you write a little faster, then this is just the definition they are asking. So it might not take 20 minutes. So sorry, 6 minutes. So you can write that little bit earlier than that, and the additional time you can allocate to another question. So like that, some components will be there that you can allocate time to other questions. So keep that in mind. So that is why anyhow, make sure that you don't spend the whole 3 hours in 3 questions. Spend the 3 hours for 5 questions, right? Okay, so the second question, you see some calculation. Okay, it's mentioned that all 330 elders living in a town, some blah, blah, blah question is there. Then present these results in a table, 20 marks. Calculate sensitivity, specificity, and predictive values. Do you think this test is good for screening dementia? Give reasons, 30 marks, right? So like that. And then validity of a screening test, 25 marks. Then again, some numbers are given. So they are asking, calculate the following: sensitivity and specificity, positive predictive value. Then again, 2 calculations, right? So are you clear that the type of questions that they're asking?
Yes.
Okay, right. So then let's move into our session. Right now, let's compare pap smear, right? So what are the 2 targets group that we are targeting for the pap smear in Sri Lanka? We target 35-year-old women and
45.
A 45-year-old women, right? Now, when the pap smear is abnormal, okay, when the pap smear is abnormal, do we go for chemotherapy or radiotherapy or anything straight away?
No. No.
No. Then we do something called what?
Colposcopy.
Or let's say colposcopy, or let's say cervical biopsy, right? Okay, so biopsy is called the definitive diagnosis for this. Is that clear?
Yes.
So now you can see that there are two tests involved. Pap smear is one test, cervical biopsy is one test. Now, if
Screening.
yeah, so two tests are included here. Pap smear is one test, cervical biopsy is another test, right? Okay. Now, if you compare these two tests, right? What is the purpose of doing the pap smear here?
Screening.
What was the purpose? Now we didn't decide the management based on the pap smear. Okay. We anyhow let the people who were abnormal pap smear undergo the cervical biopsy, right? Then the purpose of pap smear is not to decide whether to give the treatment or whether to give the management options or not, right? It was only to do what? It was to identify high risk people. And for those high risk people, we arrange the other diagnostic test or other gold standard test. Is that clear?
Yes.
Yeah, and what was the purpose of the gold standard test? Now, gold standard test, that means if the biopsy was suggestive that this needs surgery or chemotherapy or radiotherapy, then we provide that, right? Then the gold standard test, the purpose is to decide the management. Is that clear?
Yes.
But the pap smear, the idea was to get the high risk people. Then somebody might ask, why don't you just do cervical biopsy in all people? Because even if the pap smear is positive, we are doing cervical biopsy. So let's do cervical biopsy for all. Then what is your answer?
It's more
Cost-effective.
Yeah, so it's not feasible. Why? Cervical biopsy needs more resources and more invasive. Okay, it will be a waste, financial and logistical waste. Okay, so most of the time this test like cervical biopsy we do for high risk people. Is that clear?
Yes.
Yeah, and then the purpose, then the purpose of the pap smear is to identify the high risk groups, whereas the cervical biopsy purpose is to get the definitive diagnosis. Okay, and the relevance to the treatment that for the pap smear, generally the treatment is not started if positive, but cervical biopsy treatment is decided by the test. Okay, so that kind of test, pap smear kind of test are called screening test, and cervical biopsy kind of test are called diagnostic tests. So are the things clear up to now?
Yep.
Okay, and then we'll finish with the next slide, and we can continue from there next day. Now, let's say that there was a woman born in 1980, right? A woman was born in 1980, right? And the woman got some changes at the cellular level in year 2000, right? So born in 1980, got the changes in 2000, right? But no symptoms, right? Changes only at the cellular level. Then 2010, symptoms were there. Okay. Then what are the three phases that we can divide this whole process from 1982? From 1980 to 2000, there was no disease even at the cellular level. Then can we tell that as no disease phase?
Yes.
Yes, and then from 2000 to 2010, there were no symptoms, but the disease was there at the cellular level. Then can we tell that as the preclinical phase?
Yes.
Yes.
Yeah, so preclinical phase, right? And then after 2010, symptoms were there. So can we tell as a symptomatic phase?
Yes.
Yeah, so then no disease, preclinical, symptomatic. Out of these three phases, in what phase you like to do the screening test? You think a screening test would be applicable for, if you apply the screening test for the no disease phase, then will that be positive?
Negative.
No.
No. Then when the person is symptomatic, do you waste time applying screening test?
No.
No, then directly you go to the diagnostic test, right? Okay. And when the person is not having the clinical symptoms, but at the cellular level, then that is the ideal period to apply the screening test, which is for the preclinical period. Is that clear?
Yes.
Right. We'll stop there and we'll continue from there next day. Right. Okay. Then have a great day.
Thank you.
Thank you, sir.
Thank you.
Okay, thank you so much, Dr. Buddhika Mahesh, for your valuable inputs. We are waiting for our next lecturer to arrive, so we can take a small break, and we will be starting in a couple of minutes until when she comes. Okay, thank you. Hello, everybody. Are the students here? Hello?
Yes.
Yes,
Hi.
ma'am.
Okay. So yeah, a very good evening to Dr. Rema Niaz. So she's an acting consultant physician, acting committee physician from the epidemiology unit of Sri Lanka. And she would be conducting the lecturer today on the principles of prevention of communicable diseases. Over to you, madam.
Okay, thank you. Let me share my screen. Okay. Can you see the presentation?
Yes.
Okay. So this is, hello?
Yes, madam, we can see and hear you properly.
All right, thanks. So I think you might already know what epidemiology means, right? Any idea? Would anybody like to say what they understand when we say epidemiology? No? Okay. So epidemiology, the way I see it, is basically it's like the bread and butter of community medicine or public health, because community medicine is sometimes known as public health in other countries. So actually, when you say, look at the definition, it means the study of the distribution and the determinants of health-related states or events in specified human populations, as well as how such knowledge is going to be applied to control health problems. So epidemiology. So can you tell me what you understand by any health related state or event? Anybody?
Diseases.
Yes, diseases. Anything else like which are not diseases? Anything you can like think of which contributes to our health but is not a disease itself?
Risk
Anything?
factors.
Yes, risk factors. Other than that, things like maybe, you know, like even road traffic accidents, you know, so all those things actually affect our health. So we have to study those events as well as what are the factors which are bringing these on for a specific population, because in some populations it will be kind of high and in some other populations it will be low. So we are going to study why one population is affected while the other is not, etc. Okay, so does that make sense? Okay, so when we try to study communicable diseases, actually it is not one event. It's actually a process, and there are a lot of factors which are involved in this. And I think, have you heard of something called the epidemiological triad? This is not just for communicable diseases. Epidemiological triad can be used for other stuff as well. Okay, so here it shows that it's like a, you know, triangle, and it's bidirectional because one can affect the other and the other affects the starting factor as well. So what are the three important factors which are there in the epidemiological triad? As you can see, can you read it? Can someone read it? So I know you are there.
Environment.
Yes. Yes. So all of these factors exist in an equilibrium. So you understand? So when a disease or in any community, when everything is normal, all these factors are in a state of equilibrium. So when this equilibrium is lost, only you start to see the diseases coming out. Do you understand that? I think you do, right? You would have done this during your undergraduate days as well, right? So basically, when you talk about communicable disease prevention, you have to start thinking using this triad. Okay? So if you have to write an essay answer, make sure you are thinking on this concept. You are thinking of the environment, which is conducive to transmission of the disease, the host factors, which are making the person diseased, and factors about the agent. The agent is the organism. Okay? Right. So can you see the factors which have been listed there? For the host factors, we have given some characteristics. For the environment, we have given some characteristics. For the agent also, we have given some characteristics. So can someone tell me a disease? It doesn't have to be a communicable disease, but any disease which makes a person susceptible because of their age. Any health condition which makes a person susceptible because of their age. Can you think of one?
NCDs.
Yes, so NCDs are more common in which age?
Old age.
The young or old?
Old age.
Older age. Okay. What about, can you think of any infectious diseases which might be affecting a certain age group? For example, like children?
Upper respiratory infection.
Yes. Sorry? Did someone say respiratory tract infections?
Yes, upper respiratory.
Yes. So, for example, now if you have to write an essay question, you have to give a lot of examples, no? So always try to be a little bit more specific. So when you say respiratory tract infection, try to make it something more like, influenza or something like that. So, yes, crew, no? Did you say crew?
Yeah.
Yeah, okay. So, why do we give vaccination for children? Because the vaccine, most of the vaccine preventable diseases are more common in the childhood due to various reasons. Okay. So when you look at all these factors, there are a lot of factors which come and makes a host susceptible or resistant to a particular infection. Okay. Then what are the environmental factors which you know of? For example, there is lot. For example, if you take something like housing and overcrowding, what kind of infectious diseases are there? Sorry?
Leprosy, tuberculosis.
Scabies.
Scabies, yes, yes. Can you think of any respiratory infections which are there in poor?
Tuberculosis.
Asthma.
Tuberculosis.
Yeah, tuberculosis as a kind of an infection. The commonest thing you see is tuberculosis, no? It's a poor man's disease, right? So because of the social determinants, they live in crowded houses, crowded neighborhoods. So all those things make them more susceptible. Then what about the agent? What was so special about COVID-19? Why was there such a pandemic? Any idea? Why was there a pandemic when COVID-19 came? What was important about that agent, about the virus?
Virulent.
Sorry?
Basic reproductive rate of.
Yes, more than that. That is
Highly.
one factor. What? I can't hear you.
The pathogenicity.
Yes.
Virulence of the disease.
Yeah. Why was it virulent? Why was it so virulent compared to others?
Mode of transmission.
No. I mean, there are other modes, other infections which are by respiratory droplets, right? Have you ever heard of COVID-19 before it came?
No.
No. So what was special? It
It's
was
new.
it's new. So when a new virus comes or a new bacteria comes, is everybody susceptible or not? Do we have any immunity against a new virus or a new bacteria?
No.
No. So the biologic makeup of the agent is a very important factor in how many people are going to get sick, right? So those are the things which are very important, right? So just think about it and see for each infectious disease, why it might be more common in a certain population or in a certain community. So try to think using these three factors about the host, about the environment, and about the agent, right? Right. Now, in the previous epidemiologic triad, there were only three factors, right? The host, the agent, and the environment. But sometimes, for some communicable diseases, there is another factor that comes in. That is the vector. So the vector makes the triad a little bit more complicated. Okay? So what are, vector-borne diseases, right? Can you tell me one disease, vector-borne disease?
Dengue.
Dengue, malaria, mostly transmitted by arthropods, right? Right. So when you have a vector as well involved, you have to think now the factors about the vector as well. If you need to either control or eliminate or eradicate that disease, you have to think about 4 factors, not just 3 factors. Okay? Right. So when we look at the infectious disease process, I told you, no, infection is not a one-time thing. There is a process to it. So if we can break it down, because it makes it easier for us to see where we can put the strategies to control or treat it, eliminate it, eradicate it, or control it, because that's our aim, right? So the process starts with an etiologic agent. So etiologic agent will be the who? The organism, right? And then there is something called a reservoir. What is there? A reservoir. So what is a reservoir? Have you heard of a reservoir? Just give me 1 second. Okay, sorry about that. Okay, so when there is an infection, and there is a reservoir, the organism has to come out of there, right? And then the mode of transmission is how it's going to go from the reservoir to the host. And in the host, there will be something called the entry site or the portal of entry. Other than that, the host also has to be susceptible. Okay. Now, can someone tell me to take an infectious disease? I thought of leptospirosis because I thought that would be easy. And can you see what are for each of these? What is the process involved for leptospirosis? Can you quickly think about it or write it down? I'll give you 30 seconds. Okay. So I have put the answers, but can someone just tell me for leptospirosis, what is the agent, the etiologic agent?
Urine, mouse or cow.
Yeah. So the agent is the infective causing organism. So that would be the leptospira bacteria. Okay. So what is the reservoir? Where does it stay?
Rats and rodents.
Rodents.
Yes, rodents or rats. Mostly in Sri Lanka, commonly in rats. So portal of exit. How does it come out to give the infection? On what?
Through urine.
Yes, usually urine. The rodent, urine. Okay. So mode of transmission. How does it transmit to the human?
Drainage, sewage.
Sorry?
Muddy water.
Muddy water.
Okay.
In
Through wounds of the human.
Okay, so it's basically the contaminated water sources, right? So how does it enter? How does it enter the host?
Aberrations.
Yes,
Through
yes.
skin.
Broken skin, yes. How else?
Bones.
Nose, mouth.
Yes.
Eye.
Mucous membranes, yes. So abraded skin or non-abraded mucous membrane, right? And what about the host? What kind of, who are more susceptible to this? Who are the host who gets leptospirosis? What kind of people? Sorry?
Humans and mammals.
Farmers, yes. Who else?
Sewage workers.
Sewage workers. Exactly.
Victims of floods.
Okay. So already you know some. Now all this what you're talking about is actually epidemiology, right? So now already you know epidemiology for leptospirosis, so you can control it now. So other than that, now newly we have something called ecotourism, right? Have you heard where we get these tourists and local people, they go exploring in the wilderness and whitewater rafting and all this. So now newly this ecotourism also has brought on some new kind of hosts who are falling ill, right? So this is the same thing what you told, right? Right. Now there are few things, few terminology, it would be good for you to know, right? So this is how we describe the agent. So these, when you have to kind of describe the bacteria or the virus, use these terms to show that you know them, right? So what is infectivity? So infectivity is the ability of the infectious agent to enter, survive, and multiply in the host. Okay? By doing that, they are able to produce the infection or the disease. Is that okay? It has to be clear. Infectivity, pathogenicity, and virulence are kind of, those are like three different concepts, right? Then what about pathogenicity? What do you understand by pathogenicity? Does that make sense? The capacity of the infectious agents to cause apparent infection in the infected population. Okay? So if they cause the symptoms in the infected population, how much of ability they have to do that is their pathogenicity. Okay? Some will be kind of high. I mean, if say two different types of viruses are put to the same population, the number of people who show symptoms will be different for each of those viruses. Okay, so that is their pathogenicity. Then what about the virulence? What do you understand by virulence? So virulence is how severe the disease is, right? So if an agent is more harmful, then it can cause more severe disease. The more harmful the agent is, the more severe the disease is. Okay? So to measure virulence, you can use various factors. For example, morbidity. Do you know what is morbidity and mortality? What is mortality?
Death.
Deaths. So mortality is number of deaths caused by a certain infective organism. So morbidity is?
Affected by disease.
Yes, those who are going to be affected, the incidence, or you can say the incidence, because this is a infectious disease we are talking about. Basically, it will be incidence, right? And in mortality, there are like two concepts. One is called the case fatality ratio. So what is case fatality ratio? Do you know what is case fatality? So case fatality means when now let's say 100 people are infected by a certain virus or bacteria, the number of deaths per 100 infected would be the case fatality. So if case fatality is high, that means there are more deaths. Do you know a disease with 100% case fatality? Do you know an infectious disease with 100% case fatality?
Rabies.
Yeah, rabies.
Rabies. Yes, correct. Very good. So some infections are 100% fatal. If a rabies virus, after it enters the body and infects the nerve, that person will die. There is no cure, right? So, do you know, have you heard of something called the lethal dose 50, LD50? I think you might have heard it in pharmacology. Anyone would like to try what that might be?
Yes, the LD50 means The 50% of death caused because of the chemical reagent. How much of reagents? LD50 high, that means we can survive more. LD50 is low, so the harmful is high.
Yes, correct. So LD50 basically means that the dose of a chemical. Here we are talking about the dose of a organism which can kill 50% of the population. Okay? So if that dose is low, that means virulence is high. So LD50 value is low means it is a highly virulent organism. Did you understand that?
No, we didn't get it.
You didn't get it?
Yeah.
Okay. So LD50 means we are calculating like a, like a dose. Okay. Let's say if it's a chemical or it's let's say it's for some kind of a toxic chemical. So we test it, we give somebody like 5 grams, 10 grams, 50 grams, etc. to a population, right? And then there are two chemicals. One chemical kills 50% of the populations at 50 grams. The other chemical kills 50% of the population at 100 grams. So which one is more virulent? The 50 gram or the 100 gram?
Smaller dose.
Yes. So if the LD50 is low, that means it's more lethal.
Yeah.
Okay? Got it? Everybody got that? Right.
Yeah.
So there are a few more terms. So you know what is epidemic, right? So anybody would like to try to answer that one?
Abnormal number of cases reporting certain time period.
Yes. So if there is higher than expected numbers in some specified time or in some specified population, we call it either epidemic or an outbreak, right? Usually these two terms are interchangeable, right? So both mean the same thing, but in Sri Lanka, sometimes we use outbreak for epidemics which involve things like food poisoning, okay? So usually we say there was a food poisoning outbreak at this facility, that facility, etc., right? So some say that when you use the term outbreak, it gives like, this is more urgent, you have to act fast and, something we can control if we act fast, something like that. But actually both mean the same thing. And epidemic, they say it's more like when you want to say the cases are like, there are a lot of cases in like a large population, etc., that they use the term like epidemic. Okay? But remember, both mean the same thing. Right. And do you know what is a cluster? Have you heard of a cluster? Any cluster? When you say...
More number of cases in the
Yeah. So cluster is like, I think even like a normal English term. But when it comes to infectious diseases, when we say cluster, what we mean is there is a occurrence of an aggregation of cases in a given place and time, right? So we say like there was a cluster, measles cluster was there in this Colombo CMC area. So what it means is a lot of people have got the same disease, right? And what's a pandemic? What's the difference?
One particular area. It's in the vast range.
Yeah. So when so when an epidemic spreads out of control and spreads to many regions in all the world, you call it a pandemic, right? So an epidemic which has spread all over the world in many countries, covering most of the regions in the world, that would be a pandemic, right? Right. Now, let's look at a few graphs, right? Now, there is another term called endemic. What do you understand by endemic?
disease adhere to some area of some population.
Yes. So
Normal
epidemic,
compound.
yes, epidemic, I think you got the concept, right? Epidemic means the increase in a disease incidence in a specific population in a specific time. And endemic means
Throughout the time it's there.
yes. Diseases are not zero, no. Normally, even food poisoning, you hear of the food poisoning when there is an outbreak, no? When about 100 or 200 people get the same thing after eating from some same wedding or something, you hear about it on the news and then it becomes an epidemic. But food poisoning is there, no? Even in the houses, etc. 1 or 2 people might get, food poisoning and they get cured. They might get admitted, not get admitted. So for any disease, usually there is a baseline level in the community, right? So is dengue endemic in Sri Lanka or not?
Yes, endemic.
Endemic. But do you see on and off, do you see outbreaks? Do you see epidemics on and off?
Yes.
Yes. So when it becomes an epidemic, it's on the news. When it's endemic, it's not on the news. So do you understand what is endemic and epidemic?
Yeah.
So right. So most diseases are not zero, except for few diseases which are like, vaccine preventable diseases. Now in Sri Lanka, have you ever heard of a polio case? In the recent times, have you heard of a polio case? Anybody heard of a polio? No? Yes or no?
No.
No, because certain vaccine preventable diseases, we are maintaining at 0 level. So for example, polio, since 1993, there has not been a case in Sri Lanka. So for the polio, there is no endemicity, right? So there is no zero. So there is no baseline level of infection. Okay? So just keep in mind, there are few vaccine preventable diseases which do not have a baseline level. So when such a thing is there, even if you see one polio case in Sri Lanka, will it become epidemic? What do you think?
No, vaccination is there.
No, I'm just asking.
That's true.
If
That's
you
true.
hear of one child with polio,
Yeah. If
Yes.
zero, it becomes 1 also as epidemic.
yes, exactly. So for vaccine preventable diseases, for even one case for us is an epidemic because it's not there. It's 0. Okay? That's for extra knowledge. Okay? Right. Okay. So you have to learn about these curves called epicurves. As you can see, this graph, can you see the x-axis? What does it show? The
No,
time.
times.
Yes. And y-axis shows the
Number of cases.
cases. So if you draw a graph like this is called the epicurve or a epidemic curve, right? So using this, you can get an idea what is happening with this disease. This is very useful for epidemiologists. So what is this called? A epicurve. So epicurves, you will be taught later. Like I think there is like a big lecture on epicurves, but I will just give you a very basic kind of introduction to it, right? So these are 4 types of epicurves. Okay. Now this first one, that's called an epicurve for a disease with a common point source. So what that means is, there is a one-time event. For example, there is a wedding. And in the wedding, there was some kind of a contaminated meat. So people went and ate that. And then usually food poisoning starts in a couple of hours now. So within the second hour, we got 1 case. And by the 4th hour, we got 3 cases. Can you see? Gradually, the cases are increasing. Do you notice my arrow? Can you see my arrow?
Yeah.
Yes. And then it gradually
Decline.
declines and becomes
Zero.
0. Because this is a point source and it's common because many people consume from that. So if you see a chart like this, even if you don't know what was the infection, you can think, yeah, this is a common point source. So there may be, it's some kind of a similar to food poisoning, right? So just by looking at the epi curve, you can guess what can be the disease, right? So this is the typical curve for a common point source, right? Now this is what you call the common persistent source. So what has happened? Any idea? Can someone try to explain it? So by looking at the name also you can tell, no? It says persistent source. So the source is persisting in the environment. So people are what? Being exposed to it and they are getting the infection, and depending on the incubation period, people fall ill at different points in time. Can you see? Can you understand that? Now here, why are they not getting ill at the same time? Any?
Susceptibility of the exposure, susceptibility, the biological factors.
Yeah. So the biological host factors makes them
Resistant now.
yeah. Yes. Also the type of exposure. Now this source is persistent now.
Yeah.
So some might be existing I mean, they might have been exposed on day 1. Some might have been exposed at different times. And it never comes down to 0. You understand? So
Yes.
it just goes up and then it just kind of continues to go on. Okay.
Yes.
Now, this one is what we call a propagated source. Now, I'll give you a clue. This is the kind of graph you see during COVID infections. Just take a minute and try to explain to me. Okay, can you try to explain that? There is one
it
case
due to
here.
incubation period of window
Yeah, so
from the
yeah,
exposed?
but can you try to see, can you see that this is going up like this? Can you see? Can you see? This is still climbing up because we
Yeah.
have shown only small part of the curve now.
Yeah.
So that is because this is what we call a propagated source, because this is transmitted by humans. So this first person gets the infection and he gives it to 5 people. Then these 5 people give to another 25 people. The 25 people give to 5 times of that. Can you see?
Yeah.
So there is an exponential rise. So till we can either become immune or until we develop immunity by vaccination, or by until all the susceptible people are finished getting the infection, this will probably keep on climbing until we intervene. Can you see? Did you understand that concept?
Yes, yes.
So
Like
human.
this, Madam, previous two also, if you tell with one example, it's very easy to understand.
Okay, you want an example for this?
Yes.
Okay, so when you take COVID, it's only transmitted by humans now.
Yep.
Right? So when the very first person will get it, right? And then one person won't transmit it just to one person, no. So if he's moving around, he will give it to maybe 4 people or 10 people. And those 10 people, they will move around, give to one person will give to another 10 people, no.
Yeah.
So 10 into 10 is 100. Like, the price is in square numbers. So that's why it's going rapidly like this, having a lot of, it's going to peak like this. Now these are coming down now.
Yeah.
But because the persons are only infecting the other people, there is a exponential rise. So it will just go like this, like this, like this, either till they develop immunity or till all the susceptible people are done getting the infection, and automatically then it will come down. Okay? So that is called a propagated source. And this common intermittent source is, now let's say you have a Sunday fair, and in this Sunday fair you have one vendor. Every Sunday he comes and he sells some food, then he goes, and that food is contaminated. So you get a few people getting the infection, it dies out. Then again the next Sunday he comes, and then a few people get the infection and it dies. Then again the next Sunday he comes. So that's a intermittent source. The source is coming on and off. Now here it's not an intermittent source. The common source is like some kind of a contaminated water source or something like that.
Yeah.
Okay. But here you understand the difference, right? Now here some vendor is coming every Sunday, giving the contaminated food, then moving out. Giving the contaminated food, moving out. So you get a few cases, dies down, few cases dies down, and it just goes on like that till we find that vendor. Okay?
Yep.
Okay. Can you just
Madam, can you
me?
please
Yeah.
explain common persistent source again?
The common persistent source. Right.
Yes.
Can you just give me a minute? I'm getting a call. Okay. Just give me a minute. Okay. Sorry about that. Hi, sorry, I got cut off. Can you all hear me?
Yes, ma'am.
Oh, right. I think someone wanted to know about the propagated source again.
Madam, it's about common persistent source actually.
Okay, just give me a second till I put this up. Okay, now here the common persistent source, think of it like a street food vendor. Okay, now he's coming and selling food every day on the pavement. So every day, some people go and eat from him. So now every day that source is there now. So it just keeps on occurring. But the number of cases which comes is different because depending on the, number of the how many people buy each day and how much, what is their susceptibility level, whether they are resistant, etc. You see that it's kind of continuing. It's not coming down. So it just keeps on going like this. Does that make sense?
Yes, madam. Thank you.
Okay. Hi, am I back in the Zoom meeting? Hello?
Yes, ma'am.
Okay, right. Okay, now the curves you will actually learn at another lecture. So you can ask them, also you can read up on those curves, okay? Now we'll just go to see what we have to know about these reservoirs, right? So what is a reservoir or who is a reservoir? So now reservoir is an infectious agent and is in the habitat. Habitat means that is where they live, right? So the habitat in which the agent normally lives, grows and multiplies. So the reservoir harbors the infectious agent, but they are not injured by that. Because if the infectious agent harms the reservoir, obviously the agent will be destroyed. So they can live in harmony, okay? Now, the similarity is that the infectious agent is harbored by a reservoir as well as a vector. But can you think of a difference between a vector and a reservoir? Now, the reservoir need not actually be the one who transmits or carries the disease, but the vector is the one who carries a disease, okay? There's a small difference there, all right? Well, the rodent is a reservoir now for lepto, but the mosquito is a vector. So you see there, you understand the difference, right? if you, hello? Hello?
Yes, we
Yes.
can.
Yeah, sorry. Okay. Now, for example, if you look at Clostridium botulinum, you know, that is transmitted, like, you know, who causes food poisoning. The reservoir for the Clostridium bacteria is the soil. But people don't eat soil now. So they get the infection because the spores are found in canned products if they are not canned properly. Okay. So similarly, the carrier is the individual. Yes, a carrier. Who is a carrier? You know about asymptomatic carriers? Do you know there are diseases which are spread by carriers? Now, the commonest example for a carrier is typhoid.
Typhoid.
Yes, so that is a disease where you have a really healthy person, but still they are excreting typhoid bacteria from their bile. So the bacteria is excreted through the feces, and if the feces contaminates the food, the others can get typhoid. But these carriers are healthy people. They have no apparent disease. Okay? And there
So
are
the
some...
carrier will be a
Sorry?
human always.
Hello?
Therefore, the carrier will be a human always.
Usually, yeah. Carrier is a human. Okay?
Thank you.
Now, you know the portal of exit for different diseases. There are different portals of exit. For respiratory infection, the respiratory tract will be the exit. Now here we are basically talking if the disease is transmitted by a human. Okay? So there are diseases which are transmitted through the genitourinary tract. For example, like sexually transmitted infections. Then alimentary canal, the fecal-oral, then through the skin, you transmit diseases like lepto, right? And transplacental transmission is there, where transmission takes place from mother to the unborn baby. And also some infections like HIV can be transmitted through breast milk as well. Okay. So this is a small table where you can see the portal of exit and the modes of transmission. So you can leisurely go home and see what are the exit routes of exits and portal of entry, etc. Okay. Is there any question you want to ask about this? This is like really basic, right? So I'll just go on, right? Now, modes of transmission. Now, you have heard of droplet transmission and airborne transmission. Can you tell me the difference between droplet transmission and airborne transmission? What do you think? What is the difference?
Droplets are larger in size, so the distance they spread is limited compared to airborne.
Yes, exactly. So COVID was initially thought to be, what was it? COVID was it droplet or airborne?
Droplet.
Droplet. So that was why people were told to stay, was it 1 meter apart or 2 meters apart?
1 meter.
6 feet.
1 meter apart, 2 meters. So droplets don't travel far because they are heavy. They go and drop and deposit on objects. But airborne is the particles are really small. If I remember correctly, they are less than 2 micrometers. Can you just go and check? Okay. So they can travel farther away. So droplet in diseases transmitted by droplet, we can control it. But airborne transmission is very difficult to control. Okay. So when you say vehicle, that means it's basically like some kind of a foodborne infection, right? And some of these things you can read, right? So the portal of entry, basically, if it's like droplet, it will be, upper respiratory, lower respiratory, etc. Okay. Right. And there are environmental factors I think we spoke about earlier, no? what are the factors which can either make a disease more transmissible or less transmissible. Okay. Those are self-explanatory, right? Right. So have you heard of something called the incubation period? Yes?
Yes.
Right. So actually the incubation period is the time from receipt of the infection to the time where the clinical illness is manifested. Okay. So depending on the disease, the incubation period is different. Okay. For example, for something like hepatitis A, we say the incubation period is between like 3 to 6 weeks, and we say it's roughly it's about 1 month, like. Right. And why is the incubation period like, even though it's, it's like a period, no? You don't say, right, everybody gets the disease on 3 days or 5 days. So why do we have to give a period for incubation? Can you think of the reason why it's a period and not a particular point? And it's shorter in some and longer in some. What do you think?
Time to take, multiply, and within the first.
Yeah, because that is variable, no? Each individual's immune system is unique for them. So the time it takes for everything to happen in the body will be different depending on the capacity of the individual. Okay. So that's why always we give a period and not a point. Okay. So as they say, the incubation period depends on many things. The route and the dose of inoculation. Now, for example, if you take, let's say, hepatitis B, if someone gets hepatitis B infected blood, or if someone gets it through sexual contact, which will be faster? Who will get disease first? The one with the blood transfusion or one who got it sexually? Because of the... Yeah, the one with the blood transfusion. Because probably he got it directly, and also the dose is probably higher, no? And also the immune response of the host, as well as how fast the organism can replicate. All these factors decide those things. So some of the host factors which the incubation period depends on is variable, right? So as you know the immune system has two components. One is non-specific and one is specific immunity. So I think, can you go and refresh your knowledge on those factors? So non-specific immunity is easy, no? So shall we have a small discussion on specific defense mechanisms? Right. So what is active immunity and passive immunity? Can you look at this and give me some examples?
Person get the infection and immunization.
Yes. So in active immunity, the person has to develop the antibodies. So that can be developed naturally by getting the infection or artificially by getting the vaccine. Then passive immunity is the antibodies are transferred directly into the person. So natural immunity example is the mother's antibodies going to the child, and artificial immunity is when we give, for example, like tetanus toxoid. So the reason why we are giving, why are we not giving the measles vaccine at 6 months? Any idea? I think, can you remember there was a time the measles vaccine was given at 6 months? Anybody remember that time? And then we had to shift it to 9 months.
Interfere with maternal antibodies.
Exactly. Then, because then we found out maternal antibodies were still persisting at 6 months. And they were not developing the immunity, because when we give the partially killed virus, the maternal antibodies recognize it as the measles virus and they kill it. So because of that, again, we shifted the measles vaccine to
9 months.
9 months. Yes, very good. Right. Then there is another thing called herd immunity. So herd immunity is a very important concept in when we give vaccinations, right? So there are children or people in a community who we cannot give the vaccine to. But nevertheless, if we can immunize a large proportion of the community, the immunized, so that is called herd immunity. Did you understand that? Okay. So actually, the entire population does not have to be immunized. If to control or eliminate a disease, by immunizing a certain proportion of the community, we can protect all, right? Now here, when you look at this graph, now these blue stick figures, they don't have immunity. They are not vaccinated or they have not had the natural infection. And then these red figures are getting the infection. So depending on the susceptibility and status, you see there are a lot of red persons. That is, majority got the infection. Now here, few people have been vaccinated. Can you see the yellow color people? Or they have some kind of a immunity or vaccination. But nevertheless, because only few people are vaccinated, the others, a considerable number got the infection. Now here, can you see majority is immunized. Majority has the immunity. So these blue figures who can't get the vaccine, they are protected. Very few get the infection. So that is the theory behind herd immunity. Okay? You would have heard that before, right? Right. So actually to decide on the proportion we need to immunize, we have to think of the R naught, right? So this R naught is a very important concept in epidemiology, right? So that's called the basic reproduction number. So what it means is, if we have one person who gets the infection, and if all around him are susceptible, the number of persons who he infects is the R naught. Did you understand that? Did you understand that? Number of people who get the infection in an unprotected population by a single infected person. So for Ebola, this R naught is 1.5 to 3.5. For measles, it's 12 to 18. Now, if none of you have had the measles vaccine and one measles infected child comes into the room, 20 of you will get the measles infection. So that's what it means. For COVID-19, basically the R naught is around 4. And finally, they came to the number 2.63 after studying everything, but it's between 0.4 and 4.6. So as you can see, measles is highly infectious, more than COVID, right? So the thing is, the higher the R naught, the higher the immunity threshold that we must have to protect the community. So if you want to stop the measles epidemic, we have to vaccinate and immunize more than 90% of the population. Okay. Did you understand that?
Yes.
Okay.
Dr. Rima, apologies from my end. I'm Dr. Tatsa here. We are a little bit running out of time.
I know. Just can you give me 5 minutes? I'm nearly done.
All right. Thank you.
Right. So, all right. Now, really now, when you come to public health measures, there are a lot of opportunities for control. Okay. Just identify, can you see these cross marks? So everywhere, depending on the infections, there are places which you can stop the transmission and control. Do you know the levels of prevention?
Yeah.
Right. Okay. So please read up on that. There is primary prevention, secondary prevention, tertiary prevention, and something called primordial prevention. Okay. Right. Also, you have to know what is disease control, what is disease elimination, and what is disease eradication. Right. So control is you have to keep the incidence or the number of cases or the duration of the diseases, the risk of the risk of transmission, etc., at a low level. So that is called controlling a disease. Okay. Elimination means either you reduce it to 0 or you keep it at a level that WHO tells you. For some diseases like, I told you, for every disease, we can't keep 0, no. So for certain diseases, they say you have to keep 0. But for some other diseases, they say you can, if you keep it at this level, you will be able to say that this has been eliminated. Okay. And disease eradication means the disease or the organism that causes the disease is not there anymore. And the only disease which have eradicated so far is smallpox. I think you would have heard, because that's right. So there is no vaccination because it's not there in the environment anymore. Okay. And you need to know the concept of quarantine and isolation. So quarantine means if you suspect somebody has been exposed, you keep them separate from others. They are not showing symptoms. But isolation means the person is infected, the person is showing symptoms, so you are keeping them separate from others. So is there any confusion in those two terms, quarantine and isolation? Are you okay? I think that's all I want to say for today. So anyway, I will be sending this presentation. So if you want to clarify anything, I'll give my email to Satsara and she can share it with you. Okay?
Thank you.
Satsara, I will stop sharing.
Yes.
So guys, just send me your questions. I'll give you my email. Okay?
Thank you.
So thank you so much, Dr. Rimaza Niaz, for that extensive lecture on principles of prevention of communicable diseases. Now we are ready to move on to our next lecture today, which is on the principles of prevention of non-communicable diseases, which should be done by Dr. Arundika Senaran. Over to you, madam.
Okay, thank you very much. So shall I share my screen? Hope you can see my screen.
Yes, madam, we can.
Oh, okay, thank you very much. So I think now it's good afternoon still. So I'm Dr. Arundika. I'm the consultant community physician attached to the Directorate of NCD. So we will today discuss about the principles of prevention and control of NCDs. So I think most of you are from the, I don't know whether your background, you may from the curative sector or the preventive sector. All of you may have come across NCDs. Actually, NCDs is a big burden to our country at present. And so what do you mean by NCDs and what is the definition of NCDs? Non-communicable diseases. So I think Dr. Rimaza talk about these communicable diseases. So what is the difference between the communicable and non-communicable disease? A very basic question. Communicable diseases and what do you mean by non-communicable diseases? What are the features of non-communicable diseases?
They are not spread from person to person.
Yeah, they are not spread. And what is the nature of the disease? Most diseases are actually the communicable diseases are acute in nature. So, but the non-communicable disease, NCDs are chronic diseases. So once you get it, you have to live with that disease forever, and you have to take treatment. So the chronic nature of disease is a specific feature of these non-communicable diseases. So at the moment, there are some categories of diseases under this. We discuss under these non-communicable diseases, mainly the cardiovascular diseases, the hypertension, myocardial infarction, stroke, and the diabetes mellitus, and the chronic lung diseases, asthma, under that asthma, bronchiectasis, and COPD. So cancers are there, and the chronic kidney diseases are there. So these are the basic diseases. So other than this, all the other diseases that are not infectious, these eye diseases, hearing disorders, and the thalassemia, the genetically these blood disorders. And there are so many other arthritis and neurological diseases. So there are some other diseases and the chronic liver diseases categorized under this non-communicable disease. But we will discuss mainly about these disease categories. And cancer, I think you will have separate lectures. So under the director of NCD, we are mainly dealing with this cardiovascular diseases, diabetic mellitus, chronic lung diseases, and CKD and the chronic. Actually, CKD as a complication of diabetes, we are also having some programs. And the cancer, we have a separate directorate. So they will deal mainly with these cancers, but risk factors are common for all these diseases. That is one thing. So how we get these chronic diseases, chronic NCDs? So there are socio-economic factors and moderate risk factors and intermediate risk factors that will cause these chronic diseases. So once we get to the socio-economic and cultural and environmental factors. So we mainly talk about this globalization, urbanization, and population aging. So these factors, however, the people, once with the aging, people will get NCDs. And this globalization and urbanization, they will lead to see lifestyle changes, and they will these changes will lead to modifiable the risk factors. So the risk factors of NCDs. But what are the risk factors you know for developing NCDs? So I think at the undergraduate level and all level, we discuss about these risk factors. What are the risk factors for developing NCDs?
Sedentary lifestyle.
Yes, good.
Smoke.
Stress, smoking, alcohol.
Yeah, stress, smoking, alcohol intake. Okay. What are the other things?
Familial or hereditary, some people had.
Yeah, genetic component is there. Okay. So the healthy and unhealthy diet. So there are so many risk factors. So mainly we can divide these risk factors into two groups. So one is this modifiable lifestyle factors. That means the tobacco, not only smoking, the tobacco, smoke and smokeless tobacco, and alcohol intake, and unhealthy diet. So in unhealthy diet, especially we talk about the salt, sugar, and fat. So the physical inactivity, as you said, the sedentary lifestyle. And the environmental risk factors is also there. The air pollution play a major role in getting the NCDs. Those are the modifiable risk factors. That means those risk factors we can modify. There are some non-modifiable risk factors also. The age, gender, race, the family history, the genetics. So these risk factors we can't change. So these are the modifiable risk factors. So in our program, we are mainly targeting these modifiable risk factors, while we want to pay specific attention to the non-modifiable risk factors when we dealing with the screening and all the other treatment modalities. So actually these risky behaviors, there are, so we talk about five main risky behaviors. So unhealthy diet, the tobacco use, physical inactivity, alcohol, and environmental pollution. These risky behaviors will lead to risk factors. That means raised blood pressure, and the raised blood sugar levels, and the raised blood lipids, overweight and obesity. And these risk factors will lead to NCDs like coronary heart disease, diabetes, stroke, cancers, and chronic respiratory diseases. So this is a spectrum of these NCDs. Actually, what we said is today's risk behaviors are tomorrow's risk factors, and today's risk factors are tomorrow's risk behaviors. That means it's not a one-time thing. It's a sequence of these behaviors, risk factor, development risk factors, and getting the disease. So this is a spectrum of these diseases. So when we talk about this burden of NCDs in Sri Lanka, I think most of you must know. So NCDs contribute for 83% of all deaths in Sri Lanka at the moment. So it actually is a main cause of death And when we talk about the breakdown of this proportional mortality rates, at 34% of the deaths are due to cardiovascular diseases, while it's 14 for cancers and 8 for chronic respiratory diseases and 9 for diabetes and 18 for other NCDs. Actually, the 10% accounts for the injuries, and 8% is for the communicable and maternal and other nutrition conditions. So you can see the burden of NCDs. Especially, we can talk about the mortality and morbidity. I should know. I think you should know what is the mortality and morbidity. So when we talk about these diseases, we need to burden of diseases. We need to talk about mortality and mortality, morbidity due to diseases. So this is the NCD burden in Sri Lanka. And other thing is when you talk about the NCDs, the main thing we are talk about is risk of premature deaths. So actually, most of the people, as we discussed earlier, the age is a risk factor for developing diseases. So with aging, however, we can't stop they are getting some NCDs in later in their life. But our main concern is most of the people, they get the disease prematurely and die. So that is this definition for premature deaths is deaths due to NCDs between 30 to 70 years of age. That means if the person die due to NCDs between 30 to 70 years of age, we consider it as a premature deaths. So what is actually the burden of premature deaths is, so most of these people, this age group is, they are economically active people and they are breadwinners of the families. And so with these premature deaths, we will face a lot of issues in the socioeconomic issues are there, and these the family issues are there. So the children will lose their fathers and mothers. So this the most of the time the breadwinner, once the breadwinner is died, the family, the female person has to take the all responsibility, and so social issues will be there. So this is the main issue of all this the premature deaths. That's why we are talking about the premature deaths due to NCDs. Okay. I think some person have in the chat what about the psychiatric illness, are we considering as serious? Actually, NCD mental health disorders are also categorized as under this non-communicable diseases. But I think you may have different separate lectures for the mental health. It's a risk factor. We identify the stress as a risk factor for developing NCDs, but we have a separate directorate dealing with this mental health diseases. So it's actually we discuss under the NCDs, but in my lecture, I won't touch this mental health disorders. So this is actually this is the trend of premature deaths. So it's going down, but you can see the male and female, there's a big difference. The males, the risk of dying prematurely is high than the females, but the global target is here. The dotted line shows the global target, but this is the projected linear. That means if we go in this way, this is the way we are going. But there's a gap between that global target and this projected linear trend in our setting. So at the moment, the risk of dying due to NCDs prematurely is 17%. That means the people who there's a risk of dying between 30 to 70 years of age is 17%. That is the one thing we need to solve. Okay, so the fear you can, as I show you earlier, there's difference between male and females. So female, the risk of dying is lower than the males. The male is bit high. So when you talk about the risk factor, so normally we are conducting a survey that called STEP survey in every 5 years time. So the previous survey we conducted in 2015, but it scheduled the last survey was scheduled 2020, but due to this COVID pandemic situation, we couldn't complete it. So the survey took place at 2021. So the STEP survey, actually it's the national level survey. All the districts are covered, and actually it's we are taking the age group of 18 to 69 years of age to identify the main NCD risk factors we discussed about the tobacco intake of the people and this physical activity, diet, and these are the disease conditions like hypertension, diabetes, So those things are there, and mainly it has two components. One is about this questionnaire, and there we are taking some biological measurements and this weight and height, like the anthropometric measurements also. So according to the step survey results, so this is the the percentage who currently smoke tobacco daily. So 21% of the males, they are currently taking smoking daily, and altogether is 10%, the both sexes 10%. And the percentage who currently use smokeless tobaccos. The smokeless tobaccos means the beetle chewing, and there are so many other the tobacco products like barbul, tool. There are so many other smokeless. They're snipping tobacco products. So nearly 20% of the males are taking this smokeless tobacco daily, and 3.2% of the females are taking smokeless tobacco products. And altogether in both sexes, it's nearly 11%. And when you talk about this alcohol consumption, actually it's very high. Recently, this is the taking of 6 or more drinks on any occasion during the past 30 years of time. So actually, when it comes to females, it is 15.1%, and females it's 0.3%. When you consider the both sexes, it is 7.1%. So this is the results of the recent STEP survey. And diet. So what do you mean by what do you know about this recommendations for the diet? What is the recommended level? What is the recommendation for fruit and vegetable intake? Healthy fruit and vegetable intake. How many and how much fruit and vegetable we should take per day? According to the WHO recommendation. Do you have any idea? What's the recommended amount of fruit and vegetable intake? So actually we should take 5 servings of fruit and no vegetables on day. That means it says 3 vegetables and 2 fruits, like that. I know if in a weight diet it's 400 grams per day. That is a recommended level of fruit and vegetable intake. It's a healthy recommended level of fruit and vegetable. That's the WHO thing. But you do know about salt and sugar intake? What's the recommended level of salt and sugar?
Salt is 5 gram, sugar is 25 to 35 gram.
Yeah, sugar. Salt is 5 grams. Sugar, how much?
25 to 35 gram.
Okay, that's teaspoons. If you take in teaspoons, normally we say 6, no? Okay, that is, yeah. So this is a recommended level that, but the STEP survey results revealed that 68.1% they are not taking the recommended amount. That means most of the people, they are not taking the recommended amount of fruit and vegetables on daily basis. So that is also one finding for the last STEP survey. And when it's come to the physical activity, what's the recommended level? What is the recommendation for the physical activity? How we define the adequate physical activity or insufficient physical activity?
150 minutes per week.
150 minutes per week, yeah. Okay, the 30 minutes per day or in 5 days also. It's like that. Okay. 150.
Madam, previous slide, we have tell about the 5 serving. 5 serving is good for even diabetic and other NCD patient also.
Yeah, this is actually they have taken this as a it's a normal for all people.
Okay.
Okay. So the physical activity level, that's okay. The 150 minutes of moderate or intensity physical activity per week. So actually, it's the recent survey shows that only 24.2% of the males, they are having the insufficient physical activity level, while it's nearly 44% for the females. That is a very significant result. So it says that most of the females are sedentary. That is one thing. And the overweight and obesity levels. So you should know what are the cutoff points. Actually, still we are adhering to these WHO cutoffs. So we are not go by these Asian cutoffs. So according to the WHO cutoffs, the obesity overweight is defined as BMI more or less than 25 kilograms per square meter. So it's also said the females are 48% of the females are overweight, and it's 15.2% of the females are obese. So that is also very significant results. And the blood pressure. So the recent survey results shows that the raised blood pressure, actually in that survey we took the raised blood pressure as people who are having the systolic blood pressure 140 and or diastolic blood pressure more than 190, or currently on medication for raised blood pressure. That means the people who are on medication for hypertension also included in this 35%. So it says that nearly 36% of the males are having this high raised blood pressure levels, while it's 34% of the females. So that is also very significant. Actually, the previous survey, it was nearly 25%. So this time it has increased to 34%. Another thing is the salt intake. So as you correctly said last time, but the recommended level of salt is 5 grams per day. But the recent survey shows that we are taking nearly 15.1%. The males are taking 15.1. Actually, average is 15% and 13.5% of the males. That means we are taking the 3 times higher than the recommended level of the salt intake. So that is also very important, because salt intake is a risk factor for developing hypertension. So actually we are taking the hypertension as a silent killer, and it can cause so many complications and other NCDs as well. Then another thing is the raised fasting blood sugar levels. So during that survey, we are checking the plasma venous levels of the fasting blood sugar. Take the higher than 100, more equal to 126 milligram per daily. So actually the people who are having the high blood pressure high fasting blood sugar at the time of the survey or currently on medication, it's actually 14.7% for the females, 14.5% for the males. Actually, this is also very high. Earlier, the previous survey, 2015 survey, it shows 7.4%. This time it's doubled the previous value. And the total cholesterol, that as lipid is also a risk factor for NCDs. So the total cholesterol levels more than 240. So it takes as the totally 19% of the both females and males are having high total cholesterol levels during the survey. So this highlights the comparison of these previous survey and the recent survey findings. So you can see that blood pressure, blood sugar levels are raised, and this treatment, the hypertension levels are raised, and the overweight and obesity levels have increased. And so the current alcohol uses, we have also some increase. And so these are the physical activity levels also. Inactivity levels have increased, especially among these females. So this is also a important factor. So why do you think that as you see, the risk factors are increasing and the trends are also increasing? What's the reason for these increased trends for NCDs, as you know? So that may be one question you can have in the screening. So what is the reason for increased trends in high risk factors and the disease NCDs?
Fast food habit and
yes, changes in the lifestyle. Yes, people are taking more fast food due to the female occupation. The people are very busy and they don't have time to cook, home cooking. Yes. What are the other things? The availability of this fast food is also there with the urbanization. A lot of food outlets are there, so it's we can easily reach these fast food and these ready to eat food items. Okay. Yes, what are the other things? So I think you have to you should know about this demographic transition, epidemiological transition, and all these things. The demographic transition, please read these things. It's not time to explain all these things. The demographic transition means actually now the aging population, most of the people, our population is aging. That means we have more elderly population than this young population. So that is also a reason for increased trends of NCDs, because most of the people with aging, they are getting some NCDs. And the epidemiological transition means earlier most of the countries, especially in developing countries, the people having most of the people are having these non-communicable diseases like the measles. So there are so many non-communicable diseases. The main cause of the mortality and morbidity is due to non-communicable diseases. But now it has changed with time. Now the most of the deaths and these morbidity are due to non-communicable disease. That is the epidemiological transition. So, and the globalization and its impact, urbanization, industrialization, increasing migration and increasing income levels. So all these things will lead to these unhealthy food dietary habits and the sedentary lifestyle. More screen time is there. People are using these computers and all these things, so the screen time is more and people are not engaging in physical activity, and the tobacco and alcohol intake is also there, and there are stress component is also there with this industry migration and this all industrialization, urbanization. And the other thing is the media influence is also there, especially the visual and the print media. So the marketing, most of these food and tobacco industry, they are doing very good marketing with this industry, this media. That is also one reason. And the changing lifestyles, values and cultures, and also the expansion of the healthcare system. So the diagnosis is also increased because people are going for screening and people are seeking healthcare for most of the disease conditions. That is also one reason for increasing diagnosis for the NCDs. So actually, when we come to the principles of NCD prevention and control, I think you should know what are the levels of prevention. That is also for all diseases, we can go by these levels of prevention. So I think the previous lecture also Dr. Imas also discussed, I heard. We are discussing about 4 levels of prevention: primordial, primary, secondary, and tertiary. So do you know what is the difference between these 4 levels? Do you have any idea? What's the primordial prevention? So
primordial
before? Sorry, I couldn't hear you. Before?
Developing the risk factor.
Yes, that means the actually primordial level, we are mainly targeting this underlying socio-economic, the social and these environmental conditions. So before the development of risk factors, we need to stop the emergence of risk factors. That is the primordial prevention. So most of the time we are doing these primordial prevention as a whole population or for the selected high risk populations. So mainly these health policies, these the population level strategies are there to prevent emergence of risk factors. The primary prevention, at the primary prevention, what is the phase of
risk
disease?
Factor, yeah, but disease is not appear.
Not there, yeah, that's true. So risk factor is there, but disease is not there. So we want to stop getting disease. So we want to stop the disease at the risk factor level. That is one thing. So for the primary prevention is also we can target the whole population. That means the population strategies are there, and the high risk strategies. That means the individuals at high risk. So developing the diseases we can target. So that is one thing. The secondary prevention. So
disease is there without complication.
So, but disease is there, but we want to identify the disease at early stage. So sometimes the people may not, they are not symptomatic, but inside their body the disease is there. But we can identify the disease early, and we can refer them to the treatment, so we can prevent the. We can shorten the complications. So that is one thing. Complication, and this is sometimes the disease is duration also, especially in the cancers. If we early diagnose these cervical cancers by the pap smear or the some other method, so you can treat at that level, and you can prevent shorten the disease period like that. So secondary prevention mainly the screening and treatment, and the tertiary prevention, the disease is there, but we want to stop the complications. So treatment and rehabilitation is the main part of this tertiary prevention. So those are the 4 levels of prevention. This prevention, and you should know, I think it's a very basic principles of this public health. So community medicine, you need to know these things very well. Okay. So when it comes to these non-communicable diseases, the interventions we are doing, so there are some population strategies we are adapting, and as well as high-risk individual strategies are there. So sometimes the population strategy what are the things you can think about population strategies? So for all of population, we are doing these things. That's a radical thing. So we are not selecting people. It's for the whole population. We are delivering this intervention. So what are the things you can think about the population strategies? So we are doing some behaviorally appropriate population strategies, and so they are radically, we are doing it. So when it comes to this NATAC, this tobacco, in this tobacco, there are some regulations for tobacco and this food industry. So we are giving this front of pack labeling and this back of pack labeling, those things. So without anything, it's a policy or this regulation. So we are as a population strategy. But the disadvantage is even this, the wearing seat belt is it's a regulation or rule. So it's a population strategy. But the disadvantages of this is the benefit of this more individual is less. But sometimes I may wear this seat belt whole of my life, but I may not never met in accident. So that is, I think that's a, but whether I'm adhering to these regulations, I won't get any benefit. That is the thing. So it's because of this small benefit, the individual motivation is less, and actually these when it's come to these the physician motivation is also less. That is a disadvantage of these population strategies. And other thing, high risk strategies. That means we are selecting some high risk groups. So we are giving some interventions to the high risk groups. That means if we are conducting some counseling programs for these tobacco users or these alcohol users. So that is a individual level intervention. So we are targeting the specific group of people who are at high risk. So that is appropriate for the individuals, and the physician motivation is high, the subject motivation is high. So the disadvantages is sometimes it's very difficult to identify these high risk individuals, and the temporary effect is there. Sometimes even this counseling, we can do the counseling. So some people we can do the counseling and they may stop for 2 or 3-4 months, and again they can go for smoking. Like that, we have some issues with these high risk strategies, but the population strategies also. But these are the two main principles of interventions in not only NCDs, other risk factors also. So actually the screening. So we need to talk about the screening for NCDs. So as we know, screening is a secondary prevention, type of secondary prevention. That means early detection before the people become symptomatic. So that is screening we are doing for apparently healthy people, and to identify undiagnosed diseases or people at risk of developing diseases. That is the main definition of the screening. So we are conducting screen tests for the apparently healthy people. So they think they don't have diseases, to identify undiagnosed diseases or people at risk of developing diseases. This is the definition, and so this is why the spectrum of natural history of disease. When we took it, this at this phase they don't have any disease. This is the biological onset of disease, and before the symptoms appear, there's some period that they can detect by some screening test. So at this time, although they don't have symptoms, we can detect by doing a blood test or doing some measurement, doing some smear or something. So this is the period for conducting the screening. So once the symptoms are come, so we need to go for the diagnostic test. So this is the period to conduct the screening. So there are so many types of screen. The mass screening means, so for something we can screen for whole population. So it's very costly, and feasibility is also very low. So sometimes we are doing targeted screen. That means high risk groups or exposure groups. So when the environment, the occupation risk factor. So some people with occupation risk, we can do some screening for certain things, especially with them. In the NCD program, what we do is we are screening the people with people about 35 years of age. That means we think them with the age, the risk is high. So we are not going to do the whole population screening, but we are doing some targeted screening. That means people with high risk with age, or we are screening for people with 20 to 34 years of age with risk factors. So that is targeted screening. And the opportunistic screening means sometimes the people may come to the health facility for some other purpose. So I may go to this hospital to get treatment for my fever. But once the doctor check the blood pressure levels, I found to be having hypertension. That is opportunistic screening. We are not going to get screened for this particular disease, but once we go to these facilities to get treatment for some other things or some other condition, with that screening, we are it's opportunistic screening. Actually, the most of the time, the OPDs, we are checking the blood pressure levels, and sometimes in the medical clinics also we are doing some opportunistic screening. That is the main types of screening we are doing at the moment. So what is the benefit of screening? Why we do screening? Why we are spending a lot of money on screening? And especially, what are the screening programs conducting in Sri Lanka? What are the screening programs? What are the screening programs
Cervical cancer screening.
Yes, cervical cancer screening. Okay. What are the other things for the infants, the neonates?
Hypothyroidism.
Yeah, congenital hypothyroidism at the heel prick at the once they born. We are doing that thing at some fall neonates. What about the NCDs? What are the NCD screening program we are conducting? Do you know? Have you heard about these healthy lifestyle centers?
Yes.
Okay, that is a one program. So there are mainly this well-women clinic. Through well-women clinic, we are doing these cervical cancer screening as well as the breast cancer screening and all the other NCDs also. Some of the blood pressure and these fasting blood sugar levels are screened, and these neonatal screening are doing this for the hypothyroidism, and sometimes the thalassemia screening also they are conducting to identify these people. And other thing is the NCD screening. Actually, we are conducting this NCD screening through this healthy lifestyle centers at the moment. So what is the benefit of doing this screening program? Why we need to identify them early? So actually, it's early diagnosis. We can, by screening, we can early diagnose the patient, and so we when it's come to these NCDs, we can provide them this lifestyle modification. That means the dietary education and physical activity promotion like that. So we can start early treatment. So it can lead to less complications and improve quality of life. And it will be cost saving for the family as well as for the country. And if they diagnose early and when they have very good control levels, it will reduce the health system burden also. So if the people are having hypertension and they control their hypertension well, so they won't develop this stroke and this any advanced cardiac diseases in future. So it will reduce the health system burden also, and it will improve the productivity of the people as well as the country. That is these are the benefits of screening and risk factors for the NCDs and risk factors. And actually, what are there are some features of the successful screening program. So it should be cost effective. So we can't use very high-fi, very costly methods. That means the test or any other method for screening, because it's actually it should be very we need to have very cost effective things. Other thing is that it should be physically accessible. So we need to have some very accessible method of screening. Sometimes if all the people may have to go for this tertiary and secondary care to get done this screening, it won't be a good thing. So it should be physically accessible, and high quality clinical intervention should be there. If we identify some disease, we need to have some clinical intervention. Otherwise, the people may get to know they are having disease without any treatment. So the mental stress will be there. So we need to have good treatment opportunities also. And other thing, we need to have a very comprehensive screening package to provide, and it can enhance the detection and treatment. And one most important thing is that means actually they should not go to the secondary and tertiary care. We should have done this screening program at the primary healthcare facilities. So with all these things, the Ministry of Health started this HSC, the Healthy Lifestyle Centers, in 2011. And to actually, at the moment, we have nearly 1,000 HSCs, majority based in these primary medical care settings. So the HSS actually we are detection, we are doing this screening for the major NCDs, and there are common risk factors, and we know timely referral to specialized care to minimize their cardiovascular risk. So these are actually these healthy lifestyle centers. The major things we are doing is we are checking for these weight, height, waist circumference, and measuring this BMI and waist to height ratio. And other thing, this we are checking the blood pressure, and we are doing the two major blood check. These actually the capillary blood things. One thing is the total cholesterol and the fasting or random blood sugar levels we are checking. And also the most important thing, this is not a clinic actually. That is why we are using these centers. So one of what health promotion. So giving these counseling things and the health promotion is also one of the major objective of these centers. So we want to provide their health promotion, and we need to go the awareness programs, and these physical activity promotion activities are there, the dietary promotion activities are there. So there actually the center is for health promotion also, other than the screening and treatment. So we are not giving treatment. One thing is, once identified, we have to refer to the medical clinic in the same institution or specialized care institution. That is one thing. And when we talk about these NCDs, there are actually the WHO, World Health Organization, they have identified some best by interventions. That means the evidence-based effective health system interventions. So that means that interventions are most cost-effective and feasible for implementation. So you can refer this document, you can just Google it. There are the book for this best by interventions. So these are the best by interventions they have, the WHO have identified. But tobacco use, actually the tax increases, and the smoke-free indoor workplaces and public places, the health information and warning. That means that this packeted when the packet, so health warning systems are there, and bans on tobacco advertising and promotion and sponsorship. These are the 4 main interventions they have identified for this tobacco use. And the harmful alcohol use, one thing is tax increases, restricted access to retail alcohol, and bans of alcohol advertising. So both these for this tobacco and alcohol, they have identified advertising and promotion as a best by intervention. And when it's come to the unhealthy diet and physical inactivity, the salt intake, reduced salt intake they have identified, and the replacement of trans fat with the polyunsaturated fat. The trans fat is one of the risk factors they have identified, and the public awareness through mass media on diet and physical activity. So salt reduction, trans fat replacement, and the public awareness is the main 3 interventions they have identified. And this other thing, that's cardiovascular and diabetes, the counseling, and the multi-drug therapy for people with high risk of developing the heart attacks and stroke, and treatment of heart attacks and with aspirin. That is also one important intervention they have identified. So the cancer, hepatitis B vaccination, and screening and treatment for precancerous lesions to prevent cervical cancer. So those are the things they have identified as the interventions, the best by interventions. So these are actually the proven interventions, cost effective and feasible to implement. So in Sri Lanka also we are implementing these interventions. So the tax increases and the smoke, I think these are the NATA Act. You should read about this NATA, about the National Alcohol and Tobacco Authority. So there's NATA Act is also there, and health information warning. Now I think we are using this 80% of this packet about these warning systems are there. With this pictorial warning is there, but the next step is to go for this plain packaging for this tobacco, these cigarette or these packets. And one other thing, interventions to come is the most of the time people are not buying these packet, the whole packet. They are buying as single sticks. So we want to ban the sale of single sticks. That is also one thing. And advertising, the tobacco advertising. So we are also having a lot of regulations, but the industry also doing a lot of things for promote the advertising. So that is one thing. We are challenging actually the tobacco industry and the alcohol. It's a very the powerful industries. They are doing a lot of things, indirect advertising. They use a lot of these celebrities for the indirect advertising. So they are targeting these young people, and especially the women especially in our the developing the South Asian region with the culture, the most of the time the females are not taking this alcohol and tobacco. So now they are targeting these groups also. That is also one challenge. And we need to come to this prevention. We need to NCDs. There are prevention and management is there. The prevention part actually we are targeting the reducing the level of exposure risk factors. These risk factors and the management. We need to strengthen the healthcare system to provide treatment for people with NCDs and the follow up and to screen for complication. Those are things are there. So we need when we talk about in our setting, Sri Lankan setting, so we have two main documents. The two main these guiding documents in the NCD program. One is the National Policy and the Strategic Framework for Prevention and Control of Non-Communicable Diseases. That's the recent document is 2023 to 2033. So this is we have a national policy for the NCD prevention. That is one thing. And another thing that we have a national multi-sectoral action plan for prevention and control of NCDs. So the new document is 2023 to 2027. So the new, you can actually Google it, and I think both these documents are available in our website. So these are there. So what is the need of why we need a policy document and why we need a multi-sectoral action plan? So actually the policy document will provide the way how we can reach these targets. So there are so many national and international targets for NCD prevention and control. So the policy it shows the path how we can go to how we can reach these targets and these objectives. And this multi-sectoral action plan, actually the NCDs, only the health sector can't do anything. So there are a lot of other sector involvement when we took this healthy diet. So only we can, what the health sector can do is we can advise the people. We can do the health promotion, and we can sometimes we also do some regulations and all these things. But there are a lot of other sectors involved in this. The agriculture sector is there, the trade, and these treasury, and there are a lot of these industries involving. So there are a lot of other sectors. The multi-sectoral involvement is very important. The physical activity also same. So what we can do is we can promote. We can tell this physical activity is very important. So we can give some facilities at these hospital level. But there are a lot of other things, the town planning, the urban development, and when you are doing the transportation, there are a lot of things we have to improve the physical activity of the people. So all these risk factors, the tobacco is also like that. We need to help of this media, the education ministry, and the trade ministry. Lot of involvement, but they are to reduce this, especially this taxation thing. We need to have the Ministry of Finance and the policy development. So all these other sector involvement is very important. So the multi-sectoral action plan actually is a plan with it's a very comprehensive plan. So we have identified it's a 5-year plan actually. So we have identified the main the activities for the next 5 years time, with the time frame and with the responsibility, not for health, both health and non-health sector responsibilities are there. So it describes it's a very comprehensive things, and all these activities, who are the primary responsibility, second responsibility, and what is the timeline. So this is like a 5-year plan. This is a 5-year plan for the next 5 years. So you can refer this plan. This thing. So mainly in the multi-sectoral action plan, we consider 4 strategic areas: advocacy, partnership, and leadership. That is one thing. And health promotion and risk reduction, and health system strengthening for detection and management of NCDs and their risk factors, surveillance, monitoring, and evaluation and research. Those are the main 4 strategic areas we are considering at the National Multi-Sectoral Action Plan. So what do you mean by advocacy? So actually it's a public health jargon, one thing you need to know. There are some words we are using more commonly. The advocacy means we have to, what is the difference between the advocacy and this awareness? Is it same or different things? Have you
Advocacy
heard
for the powerful people, the people who can execute well.
Okay, yes. So advocacy, what our target is to change, to get some help from the, as is the policymakers, as you said, some powerful people to change something. No? So we have to advocate. Awareness programs, normally we are contacting with some normal people or some for the group of people to make aware them regarding something. So advocacy, especially we need to do for these politicians or this hierarchy of this Ministry of Health, the other ministries like that. So advocacy is very important. So actually we need the NCD, we need to identify, actually it's like health in all policies. So NCD is on in all policies. That's one thing. It should be the whole of society and whole of the nation's thing. So we can't, only the health sector can't do this. So we have to, it should be identified as a priority in national agendas. There are so many these national policies are there. These sometimes with these political changes, the policies will be changed, but we need to have some. We need to identify NCD national agenda. That is one thing. And we need to do the advocacy for the relevant ministries. So actually, most of the thing, the other ministries' involvement is very less because they haven't seen this burden of diseases, and so we need to advocate them to get their help to improve these dietary things, the physical activity promotion, the tobacco, alcohol, and the stress promotion, stress reduction. All these things we need to the help of the other ministries also. So the partnership means the multi-sectoral actions. Actually, we need to have this partnership with all the other health sector people, non-health sector people, as well as the development partners. There are some NGOs, then volunteer groups are there. The national, sometimes these civil society organizations are there. So we need to have this partnership with all these people. And leadership, actually, mainly the leadership is by this Director of Ministry of Health. Director of NCD is the leader from the national focal point. And at the district level, we have this district under the RDHS, the Regional Director of Health Services. We have the medical officer NCDs for each and every district. So district focal point is there. So at the district focal point, actually, their responsibilities is the implementation of this national program at district level. So under the guidance of the RDHS and the consultants at the province districts. So these are the things we have identified under the advocacy, partnership, and leadership. Another thing is health promotion and risk reduction. So under this, we have identified all these 5 risk factors. What are the things we have to do for the reduction of alcohol, tobacco use, promotion of healthy diet, promotion of physical activity, and reduction of air pollution. Here we are talking about this indoor and outdoor air pollution both. So these are the, under this strategy, we have identified 5 main factor things. So the health system strengthening for detection and management of NCDs and their risk factors. In this part, we are talking about the screening and management of diseases. One thing is early detection of NCDs and their risk factors at HSC level, and improve access to essential medicines and technologies for screening and management, and improve management of NCDs. To improve the management of NCDs, we have to provide these drugs availability, improve the availability of drugs, and these investigation facilities and the intervention facilities, and all other things to rehabilitation care and palliative care, and we are providing most of this the capacity building for the health staff, and developing these guidelines, and all these things are done under this strategy. And the continuity of care, actually sometimes, so all levels of care, you know that there are the primary, secondary, tertiary levels we are talking about when you talk about this healthcare system. So at all levels, all levels of care, we need to strengthen these facilities and strengthening the health workforce for NCD prevention and control. That is also one thing. That means strengthening in number as well as the quality of work, and we have to provide the increase their capacity. And the surveillance, monitoring, evaluation, and research. Surveillance system, actually, so what do you mean by surveillance? Do you know what is the I think the EPIC unit will do the more about this communicable disease surveillance. Surveillance is what is the very basic. If you say what surveillance, what do you identify, understand by surveillance?
Continuous monitoring.
Continuous collection of data for action. Actually, it's like we are continuously collecting data. So in this system, we have this HSC surveillance system. So we are collecting data from the HSC. So all the people who are coming to these HSCs, we are taking their data, and we have this national NCD HSC database. So that is the thing. But in that database, we have a lot of issues are there. Still, we are going by these hard copies. So that electronic based data system is a challenge actually. So we have to have with this PSSP project, the primary healthcare strengthening project, in some hospitals, we have strengthened this, we have identified these health information systems, and this electronic database is started, but we have issues with this human resources and these internet facilities, the continuation of these things, who are going to enter the data at the primary care. Some centers, they have already doctor and two, the minus star people are there. So how we are going to do this? There are a lot of challenges in surveillance and this NCD health information system. So strengthening information system is also one thing. So you know that we have introduced this PMR, the personal medical record, and it's going to this PHN number, the personal health number we are going to issue with at the primary health care, the empaneled population. So there are a lot of things around this surveillance to be improved and existing. So other thing, the improving monitoring and evaluation. So we are doing this monitoring and evaluation at different levels. This district, institutional level, the district level, and national level. So district level, they are conducting review meetings with these HLC people and these hospitals. And national level is also we are doing the evaluation programs, monitoring and evaluation things. And the research is also national level. We are not conducting research most of the time, other than this surveys, the STEP survey, and there are some these surveys we are conducting time to time, and also other sectors, the PG trainings, they are doing strength research. But actually strengthening research to get this evidence, because the NCDs, the evidence are changing time to time. So getting this evidence is very important, and actually we need these context specific evidence, because our country is different from the other countries, and so we can't go by always the other evidences from the other countries. That is also very important. And these are the actually targets set by the WHO, as well as these are national targets we are going to achieve by 2023. So I will share this presentation with you. These are the targets. We have targets of reduction of premature mortality, physical inactivity, use of alcohol, mean salt intake, tobacco, and blood pressure, obesity, overweight and obesity, and diabetes, and other things. Especially for this one is for this air pollution, and drug therapy and counseling, and affordable basic technologies and medicines. So there are 10 targets we are aim to achieve by 2030. So one other thing I just want to throw just to discuss it, what's the role of primary healthcare provider on NCD prevention and control? So at the primary healthcare, mainly we want to incorporate this NCD prevention and control to the primary healthcare providers. So the primary healthcare providers can be the PMCs, the PM, the primary medical care units, and the DH divisional hospitals, as well as this is OPDs at the secondary and tertiary care things. Those are the primary healthcare providers. So one thing is the NCD screening. Okay, that is mainly through the HSC, so it can be opportunistic screening. So one thing is you have to provide a comprehensive screening package. So please, I don't have a time actually. You have to read about this CVD risk assessment, and so most of the time we are not providing this comprehensive package due to several reasons. Sometimes we don't have these facilities, we don't have some strips, but one thing is we need to provide a comprehensive package, and the referral and follow up. So one thing, we are diagnosing, but we need to refer them. We need to look whether they have reached these referral centers. Sometimes we may refer the patients, but they are not. If they don't reach to these referral centers, and if they don't follow up, and if they don't control their disease status, the purpose of screening is lost. So we need to refer and follow up the patients, and the client education is very important. Most of the people, they don't know what are these terms and what is their condition. So client education and opportunistic screening, as I told you, OPD, TU inwards, we can do screening for the NCDs. Another thing, I didn't talk about much about the NCD screening program. We have challenges with the target. the coverage. So still the coverage is not that good, and the male participation is also very poor. So what we want to do is we need to go for the workplace screening. So we want to catch more people. We think that the most of the males are occupying and they are doing this, they are working during these working hours of our HSC. So we want to go to these workplaces and do the screening, annual screening, and screening for the vulnerable communities, especially these urban poor people and the state sector. There are a lot of vulnerable people are there, so they are not coming for this institutional screening. So we need to have some the customized, so some context specific interventions to improve their screening. Another thing is health promotion. So we need to client or patient education, health promotion activities. Actually, this physical activity promotion, diet, and this tobacco cessation counseling. Those things we need to do at the primary health care, and the treatment. So treatment part is also always try to go by these. We had to go by these guidelines and protocols. So from our directorate, we have developed a lot of guidelines and protocols on NCDs for the primary healthcare as well as secondary and tertiary healthcare, and the regular patient examination. Actually, with this COVID-19 pandemic situation, the people, most of the medical clinics, they are not examining the people, not checking these blood pressure levels, but it's must. So we need to do this patient examination regularly, and ensure the disease control. So the drug titration, this change in the drug doses, and this increase in the drug introducing new drugs is also important to ensure the good control of the people. And regular screening for complications are there. So most of the people, for the people with diabetes and hypertension, they may need for screening for this other renal involvement, eye involvement, and like that. So there are a lot of screening they need. The annual and this continuous screening they need to prevent complications, and appropriate repair, and the patient education. This is also lacking in our system. So the drug compliance, the side effects of the patient, these drugs, disease control, follow-up, those things people doesn't know about. People doesn't know, they don't know about anything about this. What are the drugs they are on, what are the side effects of these things. So this part is also missing in our system. That is also the other thing, well documentation. So always we need to do well document when you are doing this treatment and the screening. So those are the things they're expecting from these primary healthcare service providers, and we have developed these guidelines, especially these for this cardiovascular risk management, hypertension, diabetes, dyslipidemia, common respiratory diseases, and overweight and obesity. These guidelines are available in our website, so you can refer these guidelines. Actually, so that is what I want. Actually, within 1 hour, we can't discuss all these risk factors and all these things. This is just an overview of the thing. So if you have any questions, you can ask quickly. Oh, I think there's this WhatsApp group is there. If you need any clarification of any questions, you can just forward any questions are there. Okay.
Yes, so thank you so much, Dr. Arundika Senaratne, the Consultant Committee Physician at the Directorate of the Non-Communicable Diseases at the Ministry of Health, so for that wonderful presentation. So that concludes our sessions for today, and tomorrow we would be starting again at 8:30 in the morning. So wish you all a wonderful day and hoping to see you all tomorrow.
Thank you. Have a good day.